Hello friends, let us now come and discuss the diseases of middle ear, and we are going to start with otitis media. Now, otitis media means inflammation of the middle ear. Okay, now over here I would like to tell you that whatever I am going to treat you now in the diseases of the middle ear as well as the diseases of the inner ear, most of this will be a repetition or an application of the knowledge that we gained earlier. Remember, we discussed the anatomy of the middle ear, we discussed the anatomy of the inner ear, we have studied the embryology of the external ear, middle ear, inner ear, we have even studied the physiology, the tests of hearing and the facial nerve and its disorders. So all this knowledge now we will be applying over here in these topics. So these topics are very quick to learn if we have understood what I have taught you in the previous topics. Right? So let's start with the otitis media, inflammation of the middle ear. And the first topic that we come to is acute otitis media. Acute inflammation or acute infection of the middle ear. We have also called it as acute suppurative otitis media, ASOM. Right? Okay. So suppression means that there is pus formation. Now, all the cases may not have pus formation. Some cases may just have an infection. So, acute otitis media is a more holistic term and is a more preferred term nowadays. But ASM is traditionally being used. So, both you can use interchangeably. Right? So, acute otitis media or acute suppurative otitis media. Now, most common causative organism. The most common causative organism is Streptococcus pneumoniae. Right? Streptococcus pneumoniae. We also call it as pneumococcus. Right? Now, second we can have is Moraxella catarrhalis. And then we can also have Haemophilus influenzae. Right? Now, how does the infection comes to the middle ear? You see, if the tympanic membrane is intact, the only way the infection can come is through the eustachian tube. Right? So, the eustachian tube is normally closed at rest, but it opens when you yawn and when you swallow. And this tube connects your middle ear to the nasopharynx. Right? And this tube may bring the infection if there is infection in the nose or the nasopharynx. Okay, now we have already studied about the eustachian tube. That eustachian tube is shorter and more horizontal in children as compared to the adults. So therefore, this disease is more common in children. Right? Okay, now based upon the functions of eustachian tube. So remember, what were the functions of eustachian tube? Number one, it maintains the middle ear air pressure. Okay, equal to outside atmospheric pressure. Number two, it drains the secretions of the middle ear. All right. So, based upon these two functions of the eustachian tube, the middle ear infection, acute otitis media, may be divided into 4 stages. So, what are these 4 stages? Let's study about them one by one. Stage 1 is stage of tubal occlusion. Okay. Now, what happens in this stage? In this stage of tubal occlusion, now there is infection. Where is the infection? In nose and nasopharynx. Okay, now because of this infection in nose and nasopharynx, what happens? The eustachian tube gets occluded. Okay, so tubal occlusion or gets blocked. Now, which end of eustachian tube is blocked? Of course, the nasopharyngeal end. Okay, so the nasopharyngeal end, which is the cartilaginous end, that gets edematous and it gets blocked. Now, what happens because of this? As soon as the eustachian tube is blocked, what will happen? The air exchange will stop. Remember, first function of eustachian tube to maintain the air pressure. So, air exchange will stop. So, now what will happen to the middle ear air? We know by the anatomy and the physiology, we know that this middle ear is lined by mucosa. The mucosa, it always absorbs some air from the surface. That also we have studied earlier. So because it absorbs air from the surface, what will happen? Now the air pressure inside the middle ear will go down. Okay, so the air pressure, it starts going down. And what will happen because of that? You see, there is a negative air pressure in the middle ear. And what will happen because of the negative air pressure? Look over here, the tympanic membrane. You see, this tympanic membrane is retracted. Okay, so you see, the tympanic membrane is retracted. Anything else? So because it is retracted, the cone of flight is distorted or is even absent sometimes. Okay, the cone of flight, it is distorted and it may even be absent. Right? Anything else? This tympanic membrane, it loses its shine. It shines because it reflects the light. So once it is retracted, the angle changes. So this tympanic membrane becomes dull, non-shiny, okay, lusterless. So dull, non-shiny, lusterless. Now what will be the complaint of the patient? What will happen to the patient? Why this patient will come to you? You see, you pull something, what will happen? There is pain. So you suddenly pull some part of the body, there is always pain. Okay, so patient will have pain. Another thing, now the tympanic membrane is retracted. So when it is retracted, it is not able to vibrate. So because it is not able to vibrate, now this patient will have hearing loss. Okay, if I ask you what kind of hearing loss, you can all now tell me it is, sir, conductive hearing loss. Okay, so of course the patient does not know conductive hearing loss. That's what we will find out. The patient will come to you with complaint of pain and hearing loss. Right? Okay, so that is your stage 1, stage of tubal occlusion. Now let's say what happens. Let's say the patient does not come to you in stage 1. Now what will happen? Now you see the eustachian tube is blocked. So what was the second function of eustachian tube? Drainage of secretions. So after some time, these secretions, they will start accumulating inside the middle ear. Right? So secretions, they start accumulating inside the middle ear. And because of these secretions inside the middle ear, what will happen? They will put pressure on the tympanic membrane. So you can see over here, you can see there is a bulge in the tympanic membrane. So you will see the tympanic membrane is bulging out. Okay, so stage 1, it was retracted, tubal occlusion. Stage of pre-suppression, now it is bulging out. Why it is bulging out? Because of the pressure of the secretions. What kind of secretions are these? These secretions are your mucoid or serous secretion. Right? Now, are they infected or non-infected? Now, this question has been asked multiple times. Earlier, it was believed that at this stage, there is no infection in the middle ear. Okay, the infection is there in the nasopharynx. Why? Because we were not able to culture any bacteria from these secretions. So the culture was sterile. So therefore, it was thought that this fluid right now is sterile. But now we have the PCR. Okay, with this PCR technique, we have been able to identify that this fluid, it contains bacteria. So we no longer call this fluid in the middle ear in the stage of pre-suppression as sterile. Okay, it may have some bacteria. So it's a mucoid or a serous fluid. It is not yet converted into pus. Okay, it is not yet suppression. This is a stage of pre-suppression, but yes, some bacteria are present in the secretions. Okay, and because of these secretions, the tympanic membrane is bulging out. Now, if you look at this tympanic membrane, you will see that these blood vessels on the tympanic membrane, they have become prominent. Okay, so you can see all these blood vessels, they have become prominent, and this gives a cartwheel appearance to the tympanic membrane. Okay, so this tympanic membrane is known as cartwheel appearance. Right? Okay, now what happens after this? This fluid, it converts into pus. Okay, so the fluid converts into pus, and pus means pain. So now we have the stage of suppression. So what does pus means? Pus means that there is bacteria, then there is macrophages, then there is white blood cells. So all of them, they come into this fluid, so it becomes a pus. Now pus means pressure. Okay, so there will be a lot of pressure, and pressure will of course means there will be a lot of pain. All right, this patient will come to you with severe pain in the ear. Right, patient comes to you with severe pain in the ear. Now what will you do for this patient? Patient comes to you, says, I have severe pain in the ear. Right, okay, you see the pain has increased tremendously from stage 1. In the stage of tubal occlusion, there was some pain. Stage of pre-suppression, the pain increased. Stage of suppression, the pain has further increased. It has become very, very severe pain, intolerable pain. Okay, now the hearing has also decreased. Okay, stage 1, stage of tubal occlusion, there was some hearing loss. Stage of pre-suppression, hearing further decreased, and now stage of suppression, hearing has even further decreased. Why? Because there is fluid. Fluid does not allow the tympanic membrane to vibrate at all. It reflects back all the sound waves. So the hearing has decreased quite a lot. All right, but the patient main complaint will be severe pain in the ear. He wants relief from the pain. What will you do? First thing, you will determine what is the cause of this pain. So what you do, you take the finger and you press on the tragus. Remember, in case of acute otitis externa, we discussed when you press on the tragus, there is pain in acute otitis externa. That is known as tragal sign positive. Okay, so remember, tragal sign is positive in acute otitis externa that I have taught you earlier, but it is negative in acute otitis media. Okay, so when you will press the tragus over here, the tragal sign will be negative. Am I clear? So stage of suppression, patient comes to you with severe pain, you keep your finger on the tragus and press it, there will be no pain. Tragal sign is negative. Right? So now you will look inside the EAC on the tympanic membrane. What do you see? You see that the tympanic membrane is red. Okay? It is congested. It is bulging. Okay? How much bulge? It is so severely bulging that it is about to burst. Right? So you have red, congested, bulging tympanic membrane about to burst. All right? Now what happens? This tympanic membrane bursts. So if the patient will not come at this stage also, the tympanic membrane will burst. And when the tympanic membrane bursts, what will happen? The pus comes out. So you see over here, the pus comes out, and when the pus comes out, the pressure goes down and the pain goes down. Okay, first question, this is known as stage of resolution. So the stage of resolution starts with perforation. Okay, tympanic membrane perforation. Why? Because when the perforation happens, pus comes out, pain goes down. Now question, most common site of tympanic membrane perforation. So as you can see over here, this is anterior-inferior quadrant. Okay, why anterior-inferior quadrant? Why only anterior-inferior quadrant? Because that is the most dependent quadrant. So friends, this is the most dependent quadrant. So you see, by gravity, the pressure will be a maximum at the bottom, of course. So therefore, the bottommost quadrant, the anterior-inferior quadrant bursts and the pus comes out. Right? Okay. Now, let's look over here in this video. What do you see? You see that there is a perforation. Okay, so you can see that there is a perforation, and you can see from this perforation the fluid is coming out. Right? So you can all see the fluid dropping by drop, the fluid is coming out. Now whenever a drop forms on the perforation, it reflects the light. Okay, so you can see it is reflecting the light. This is known as lighthouse sign. Right? This is known as lighthouse sign, and this lighthouse sign is seen in acute otitis media. Somebody asks you which stage? It is stage 4. stage of resolution, because stage of resolution starts with perforation, and only when there is a perforation we will see this lighthouse sign. Right? Okay, now something else that you can see. You see, if I clear all this fluid, from the EAC, okay, if I clean all this fluid from the EAC, now what happens? Sometimes the fluid has been suctioned from the EAC, that means fluid from the middle is also empty, and after some time if I see, what will happen? I'll again find fluid in the EAC or the middle ear. Now from where has this fluid come? If I have cleaned the EAC and the middle ear, so where has this fluid come? This fluid comes from the mastoid. Remember, middle ear volume 1 ml, mastoid volume 5 ml. Okay, so the mastoid acts as a reservoir. So if there is more fluid within a few minutes of cleaning the EAC or the middle ear, that means the fluid is coming from mastoid. Okay, that means the mastoid is also involved in the middle ear inflammation, and that is known as mastoiditis. Okay, that's known as mastoiditis. So we will talk about mastoiditis in some time. So just to tell you that in the stage 4 of acute otitis media, we have the lighthouse sign, and similar sign to that, if you clear the secretions, this discharge, and again more discharge comes, that is known as reservoir sign. That is seen in mastoiditis. That's a complication of acute otitis media. We will study it later. Okay, now let's come back to the stage of resolution. So now we have a perforation, most commonly anterior inferior quadrant. The pain has gone down, right? What happens to hearing? What about the hearing? Now you see this perforation after a time of 3 to 6 weeks. So in 3 to 6 weeks time, this perforation heals. Okay, so as you can see over here, the same patient after 3 to 6 weeks, the perforation has healed. So when it heals, the hearing comes back to normal. But if you notice over here that this patient, if you notice over here, you will see that during healing, what has happened, the epithelial and the mucosal layer have grown, but the fibrous layer does not grow. Okay, the fibrous layer does not grow. So that means a healed tympanic membrane. This is a dimeric tympanic membrane. Okay, so remember I taught you impedance audiometry. There I taught you dimeric tympanic membrane has a D curve. So I said D for dimeric. Alright, so this is the dimeric over here. You see that dimeric tympanic membrane has 2 layers, the epithelial layer and the mucosal layer. The fibrous layer does not grow. Okay, so this question has been asked. Healed tympanic membrane has how many layers? Normal tympanic membrane has trimeric structure. Okay, so there are 3 layers in a normal tympanic membrane. Okay, now let's look at this photograph. This is the photograph of a healed tympanic membrane, and you can see over here that there is a beautiful dimeric tympanic membrane. It looks like a big perforation, but only when you look at it carefully you will find a very thin dimeric tympanic membrane. Okay, so that's a healed tympanic membrane. So now let's come to the treatment of acute otitis media. Treatment of acute otitis media. So let's discuss this treatment stage wise. So stage 1, stage of tubal occlusion, and stage 2, stage of presuppuration. What happens in these 2 stages? The infection is in the nose and nasopharynx. Because of that, the eustachian tube is blocked, and that is what is causing the problems. So what can you do? There's a bacterial infection, you give antibiotics. Okay, now what antibiotics will you give? Now antibiotics always depend upon the type of bacteria. So we have Streptococcus pneumoniae, we have Moraxella catarrhalis. So what you can do is you can give antibiotics such as amoxicillin or ampicillin. Right? Okay, now what else? There is pain. So because there is pain, you will give this patient analgesics such as NSAIDs. Right? Anything else? There is eustachian tube blockage. You want to open the eustachian tube. So what you can do is you can give this patient nasal decongestant drops. Okay, nasal decongestant drops. For the first few days, you can give this patient nasal decongestant drops. What is the benefit of these drops? These drops, such as xylometazoline, oxymetazoline, they will decongest the nasal cavity and the eustachian tube. Okay, and they will open the eustachian tube and our problem is solved. All right, now the patient comes to you in stage 3. Stage 3, stage of suppression. Okay, patient has taken antibiotic, patient has taken analgesic, there is severe pain. Patient has come to you with severe pain for pain relief. There is no pain relief despite taking analgesics. So now what will you do? You see, there is pus inside the middle ear. So now you will drain the pus. How will you drain the pus? You will do myringotomy. Okay, so you will do myringotomy. Myringotomy means giving an incision on the tympanic membrane to drain the fluid. Okay, so myringotomy is incision on the tympanic membrane. Now, where should I give the incision on tympanic membrane? You see, what do I want after my incision? After my incision, I want two things. Number one, I want all the fluid to come out. And number two, I want the incision site to heal quickly. Okay, so now you see the tympanic membrane, it has different rates of growth. Maximum rate of growth is seen in the posterior superior quadrant and the minimum rate of growth is seen in the anterior superior quadrant. All right, so like this. All right, you can say it like this. Maximum in posterior superior, minimum in anterior superior. Right, now more the rate of growth, more the rate of healing. Okay, so maximum healing, quick healing will take place in the posterior superior quadrant. But if I give an incision in the posterior superior quadrant, it is in the superior part, you see the pus will not come out. The pus will always come out from the inferior quadrant. Okay, so where will I give my incision? I'll give my incision in the posterior inferior quadrant. Okay, remember, because I want the pus to come out. First thing, I want pus to come out, so posterior inferior quadrant, I will do my myringotomy and drain the pus from the middle ear. Right, okay, now you can see over here the myringotomy is done and you can put a microsuction also and you can clear all the fluid from the middle ear. Okay, so remember, myringotomy for acute otitis media is done in posterior inferior quadrant. Okay, now what happens in stage of resolution? So stage of resolution, you see the pain has already gone. The pus is coming out, the pain is already gone. All right, now there may be a perforation which will heal within a few weeks time. So the policy in the stage of resolution is wait and watch. Okay, so the policy is wait and watch for the perforation to heal on its own. So usually in 90% of cases, these perforation, they heal on its own. Okay, you can at the max give antibiotics to the patient if there is an active infection. If there is no infection, the pus is gone, the ear has started to become dry, nothing to do, just ask the patient to prevent water entry in the ear while taking bath. Okay, and nothing else has to be done. You have to wait for next 3 to 6 weeks time for this tympanic membrane to heal on its own. All right, okay, so that was the treatment for acute otitis media. Let's discuss the complications of acute otitis media. All right, so let's talk about the complications of acute otitis media. Now, when I say the complications of acute otitis media, somebody asked me what is the most common complication. It is perforation. Okay, so you see in 90% cases perforation heals and patient becomes all right. But in 10% cases, this perforation may become a permanent perforation. Okay, so in fact 10 to 12% cases we may have a permanent perforation. So that may cause recurrent infections, that may cause hearing loss, and this is known as chronic otitis media. Okay, so perforation is the most common complication of acute otitis media. All right. Now, if perforation is not given in your options, then you can mark your answer as acute mastocytitis. Okay, you can mark your answer as acute mastocytitis. In 6 to 7% cases of acute otitis media, we have acute mastocytitis. So what do we mean by acute mastocytitis? Acute mastocytitis simply mean that the infection has now traveled from the middle ear and has now involved the mastoid. Okay, so the mastoid of the patient is inflamed. What will happen to the patient? Patient will have more pain. The pain will of course increase. Okay, this patient may even have fever now. Remember, the patient is a child, right? Patient is a child, patient will have pain, patient will have fever. On examination, what you will find? You will find tenderness. Now, where will you see the tenderness? If there is mastocytitis, you will see the tenderness in the Simba concha. Remember, Simba concha is the anatomical landmark for mastoid antrum. Okay, so you'll find tenderness on the Simba concha. You can also feel the tenderness behind the pinna and sometimes at the mastoid tip also. Right? Okay, so patient has pain, more pain. Patient may even have fever. Now, what else? What else? You see, when you examine this patient, you will see that his mastoid is red, congested, and smooth to touch. You see over here, it is smooth to touch. Normally, if you touch your mastoid over here, you will feel it is a rough bone. But now over here, this is smooth to touch. Just like you iron your clothes and the wrinkles are gone, they become a little hot. They may become red if you iron too much, okay? So they become red, they become hot, and they become smooth. So similarly, the mastoid over here is red, it is hot, and it is smooth to touch. This is known as ironed out mastoid. Okay, remember there are three signs seen on mastoid. Which are these three signs? Number one is the ironed out mastoid, and as we discussed, it is seen in acute mastocytitis. Number two, we have hematoma over mastoid. Okay, so this is your hematoma over mastoid. This is known as battle sign. Okay, this is known as battle sign. It is seen in middle cranial fossa fractures. Fractures the middle cranial fossa, we have hematoma over the mastoid known as battle sign. Okay, sometimes we have edema over the mastoid. So you see, we have edema over the mastoid, and this edema over the mastoid is known as Gressinger sign. So if you remember the anatomy, we have discussed Gressinger sign. Gressinger sign, remember the girl who was a singer. Which girl? The extramarital affair. Okay, so MS3 vein. So Gressinger sign is because of thrombosis or blockage of the MS3 vein. And why this MS3 vein undergoes blockage? Because this drains into sigmoid sinus, which is thrombosed. All right, so Gressinger sign is seen in sigmoid sinus thrombosis, and that's because of the thrombosis of the MS3 vein. Okay, this MS3 vein drains the fluid from the surface of the mastoid process. So therefore, there is edema over mastoid process. Right? So remember, extramarital affair with a girl who is a singer. So extramarital MS3 vein, and we have a singer. So girl is a singer, Gressinger sign. All right. So these are the signs which are seen over the mastoid. All right. So what is the treatment for acute mastocytitis? So once again, this is a bacterial infection. The infection has now become more widespread. Okay. So now once again, you have to give antibiotics. Okay, now these antibiotics are now systemic antibiotics. You will prefer IV antibiotics if the condition is worsening. Okay, number two, you have to give analgesics. And once again, if there's a lot of pain, you may also need to do laryngotomy. Remember, as I told you, in acute mastocytitis, the reservoir sign is positive. This reservoir sign I have already discussed along with the lighthouse sign. Okay, right? So that was acute mastocytitis. Now let's look at this question. A young man with history of ear infection. Okay, so there is a history of ear infection already, presents with a smooth erythematous swelling on the mastoid process as shown. What is the most likely diagnosis? So you see, now there are a few hints in this question. Okay, number one hint is that the patient already has a history of ear infection, and now there is a smooth erythematous. So the word mentioned is smooth and erythematous, red color swelling, okay, on the mastoid. So you can see over here, so there is swelling over here. So now what is this? This is a acute mastocytitis. All right, this case is a case of acute mastocytitis. Clear? Next, a boy with history of ear discharge. So there is a history of ear discharge presented with pain in the ear and hearing loss. All right, on examination, red was present behind the ear. So you can see over here, the mastoid surface is involved. The mastoid is involved. There is redness was present behind the ear. Okay, so patient is talking about the iron out appearance of the mastoid, and then there is a reservoir sign was positive. So all the hints are given in the question. All right, what is the most likely diagnosis? Of course, the most likely diagnosis is acute mastocytitis. You see, acute mastocytitis follows ASM. So ASM was also in the options, but now this is not just acute suppurative otitis media. This has complicated into acute mastocytitis. So acute mastocytitis is of course a better answer in this question. All right, so answer is acute mastocytitis. Right, so that was acute mastocytitis. Now let's come to this question. The given below image in a patient with history of road traffic accident shows. So you can see over here, this is a patient with road traffic accident, RTA. So there is a head injury, okay, and now what you can see over here, there is hematoma behind the pinna. Okay, hematoma behind the pinna seen in middle cranial fossa fracture, and this is known as Battle sign. Right, so that is our answer. The Bizold abscess, Sitley's abscess, I will discuss later on. Rissinger sign we have already seen, that is edema over the mastoid process. Okay, so this question was asked recently in the NEET PG January 2020 exam. All right, let's go over here to the next, coalescent mastocytitis. Okay, coalescent mastocytitis. So now you see what happens. Suppose there is mastocytitis. There is acute mastocytitis. Now what happens because of that? The mastoid is inflamed. Okay, the mucosa of the mastoid is inflamed. Now because of that, you see sometimes the itis may get blocked. All right, now the itis may get blocked. And what happens after this? The middle ear becomes all right. Because of the antibiotic therapy and all, the middle ear becomes all right. But the mastoid, the inflammation in the mastoid remains. Okay, and what will happen? If this infection remains for a long term, what will happen? All the air cells of the mastoid, they will be filled with pus. And the walls of these mastoid air cells, they will start dissolving. Okay, they will coalesce to form one big cell. So it is known as coalescent mastocytitis. Okay, coalescent mastocytitis. So number one, coalescent mastocytitis is a chronic complication. It is a chronic complication of acute otitis media. And what happens in this? The patient presents with long-term or persistent pain over mastoid. Okay, patient presents to you with long-term or persistent pain over mastoid even after resolution of middle ear infection. Okay, so even after resolution of middle ear infection, patient will have pain over the mastoid. Now why the patient has pain over the mastoid? Patient has pain over mastoid because this mastoid still has an infection. Okay, so there will be dull, aching pain that will keep on happening over the mastoid process, right? And what is happening inside the mastoid? Inside the mastoid, all the air cells are being dissolved. They are filled with pus, they are being dissolved, and now they start coalescing to form big cell that is filled with pus. Now, what do you see in the examination? Okay, now how do you confirm your diagnosis? You confirm your diagnosis with the help of a CT scan. So now what do you see in the CT scan? In the CT scan, you will see that these cells, they are all filled with pus. Look over here, these cells over here, they are filled with air, whereas these cells, you can see, they are filled with fluid. We call it as clouding of air cells. Okay, so you will see clouding of air cells. Not only that, in the clouding of air cells, sometime may be seen in acute otitis media also. You see, not only that, what will you see? You will see that instead of multiple small cells, now you will see large, big cells, and sometimes you may see a single cell, because all the cells will be coalesced to form a single cell, right? So that is your coalescent mastocytitis, right? And what do you see? You see clouding of air cells in the CT scan. Okay, now how do you treat a patient with coalescent mastocytitis? How will you treat? The treatment of coalescent mastocytitis, the current treatment is 3 weeks of IV antibiotics. 3 weeks of IV antibiotics. Okay, now remember, this disease was earlier known as surgical mastocytitis. So this is an old name. We don't use this name nowadays for coalescent mastocytitis, but earlier this name was given. Okay, we don't use it now. Why? Because earlier all the patient of coalescent mastocytitis, they will be taken up for surgery. But now we have very good antibiotics. So the treatment of choice, the current treatment of choice is 3 weeks of IV antibiotics. Now, if the patient does not resolve with IV antibiotics, then only you go for surgery nowadays. Okay, so what surgery you will do? You will do mastoidectomy. Which type of mastoidectomy? You will do simple or cortical or Schwartz mastectomy. Okay, simple, cortical or Schwartz mastectomy. This mastectomy I will explain to you later. So just remember, mastectomy is done only when 3 weeks of IV antibiotic does not work. Why? Because it's a bone infection. So unless you treat the infection, patient will not have relief. Okay, right. The next topic in the diseases of the middle ear, that is the serous otitis media. Okay, so now what do we mean by serous otitis media? The term serous otitis media can also be said as mucoid otitis media or secretory otitis media or non-suppurative otitis media or even glue ear. So what is this condition? This condition is long-standing fluid collection in the middle ear. Okay, so this condition basically means a long-term fluid collection in the middle ear. Now, why there is a fluid collection in the middle ear? So you see, the middle ear we know is connected to pharynx with the help of eustachian tube, and it is the function of the eustachian tube to drain the secretions from the middle ear. Okay, but if this eustachian tube gets blocked, if this tube is blocked, then the fluid will collect inside the middle ear. So serous otitis media, this is basically a disease of eustachian tube dysfunction. Okay, so the main problem is that the eustachian tube is not working, it is not opening. Okay, now why the eustachian tube is not opening? The eustachian tube may not be opening because of multiple reasons. What can be the reasons? Number one, there can be some tumor. Okay, so there can be some tumor in the nose or nasopharynx. Okay, tumor such as JNA, juvenile nasopharyngeal angiofibroma. So we'll talk about it. There can be malignancy. Alright, there can be malignancy such as nasopharyngeal carcinoma, we call it as NPC. So this also will talk in the nasopharynx. There can be polyp such as enterochoanal polyp. Okay, so that comes from the nose and it hangs in the nasopharynx. So that polyp we'll discuss in the nose, and this can also cause the blockage of the eustachian tube. Then there can be a mass like adenoid mass, right? So adenoid hypertrophy is generally seen in children around the age of 5 to 7 years, and that can lead to the blockage, right? Okay, so again, these can lead to blockage. Even the chronic infection, the chronic infection of the eustachian tube, that can lead to scarring of the eustachian tube, as we have discussed earlier in the eustachian tube topic. So this chronic infection leads to scarring, and because of that, once again, we may have a eustachian tube dysfunction. Okay, so there can be multiple reasons why there is fluid inside the middle ear. Now, what is the complaint of the patient? You see, because of this fluid, whatever sound strikes the tympanic membrane, now this sound will be reflected back. Okay, so the patient will come to us with complaint of hearing loss. Right? This patient has complaint of hearing loss. What kind of hearing loss will this be? When you examine, you can find out that this is going to be conductive hearing loss. Any other complaint? What about pain? No. Usually there is no pain. Why? Because it's a chronic long-standing disease. Pain is generally not seen in chronic diseases. If the pain will be there, it will be a dull, aching pain. That's it. No severe pain over here because it is a chronic disease. Alright. So main complaint of the patient will be hearing loss. Now, what do we find on examination? On examination, we can see that because of this chronic bulge, the tympanic membrane, it is bulging and it becomes thin. Okay, this tympanic membrane becomes thin because of the constant pressure, it becomes thin. And this thin bulging tympanic membrane, it has become so thin that we can even see the fluid behind the tympanic membrane. Okay, so we have a thin bulging tympanic membrane with fluid behind tympanic membrane in the middle ear. Now in some of these, you can see that there are air bubbles. Okay, so in the fluid you can see the air bubbles, right? Sometime you can see the air fluid level. All right, so you can see over here there is a air fluid level. All right, so this will confirm that there is actually fluid behind the tympanic membrane in the middle ear. Okay, now sometimes you can even see a blue tympanic membrane. Okay, so you can see a blue tympanic membrane also. That is because of the venous stasis. So because of this pressure, the venous blood, it becomes stagnant in the tympanic membrane. So venous stasis in the tympanic membrane. Now the blue tympanic membrane is seen in different conditions. Which conditions? Number one, I just told you, it is seen in serous otitis media. Another condition, yes, it may also be seen in case of hemotympanum, blood in the middle ear. Okay, so now this is known as log-ear sign. So what is log-ear sign? Log-ear sign is the blood in the middle ear seen in middle cranial fossa fracture. Okay, so if there is blood in the middle ear in middle cranial fossa fracture, that's known as log-ear sign, right? Okay, and what do we have in this log-ear sign? We have the blue tympanic membrane, the hemotympanum. Other than that, we can also see the blue tympanic membrane in cholesterol granuloma. Cholesterol granuloma, it actually forms in a long-standing fluid collection in the middle ear. Okay, so this is a result of a fluid collection in the middle ear. We have a granuloma formation. It's a cholesterol granuloma. It has a pink color. Right, so these are the three conditions where we have blue tympanic membrane. Now remember, sometimes a question is asked and the glomus is given in the choice. So remember, glomus is a tumor of the jugular bulb. It has reddish blue tympanic membrane. So we'll talk about glomus. We will see the photographs of the glomus in the future topics, and you will see that the glomus is not blue, it is reddish blue. There is more red than blue. Okay, so that is a different condition. If the blue tympanic membrane is asked, if this question is asked, which of the following does not have a blue tympanic membrane, and you have these four choices: serous otitis media, hemotympanum, cholesterol granuloma, and glomus. So the answer obviously you have to mark is glomus, right? Okay, now how will you confirm this patient has serous otitis media? Number one, the patient comes with hearing loss. So what you will do? You will do a pure tone audiometry. So what will this pure tone audiometry show to you? The pure tone audiometry show to you that the patient has AV gap. That means patient has conductive hearing loss. Okay, how much conductive hearing loss the patient will have? The patient have 25 to 30 decibels of conductive hearing loss, right? Okay, anything else we can do in this patient? Impedance audiometry. Now in impedance audiometry, what will you find? We have already discussed this. Come on, there is fluid in the middle ear. Patient will have B type curve. Okay, remember, B type curve, flat curve. So I told you flat curve seen in fluid in middle ear. Okay, so fluid surface is flat, the curve is also flat. Remember, we discussed the impedance audiometry. Okay, so this will confirm that there is fluid in the middle ear, right? We have the serous otitis media. Now, how will you treat a patient of serous otitis media? Okay, so now treatment of serous otitis media, you have to remember one thing, that treatment of serous otitis media, the first thing that you have to do is treat the cause. So as we discussed that there can be different cause, there can be polyp, tumor, malignancy, even adenoid hypertrophy that can cause the obstruction, or maybe sometimes stenosis of the eustachian tube because of chronic recurrent infections. So you have to treat the cause. Unless you treat the cause, this problem may not be treated. Okay, so you have to treat the cause. Now after this, or along with this, you can do one more thing. You can remove the fluid from the middle ear, okay, so as to give hearing relief to the patient. So till the eustachian tube becomes functional, you can remove the fluid from the middle ear. So now how will you remove the fluid from the middle ear? You will do a laryngotomy. Okay, now that means you will do a laryngotomy. Okay, now the question is, where will you do this laryngotomy? Which quadrant? You want your laryngotomy to stay for a longer time. Why? Because you want the fluid to come out, okay, and you want the eustachian tube to open up. So opening the eustachian tube may take some time. Okay, the healing may take time. So you have to wait for a few weeks, maybe a few months. So you want that your laryngotomy should stay for that much time. So where will you give? Okay, you will give the incision in the anterior inferior quadrant. Why not anterior superior? That will take the longest time, because if we do in the superior quadrant, the fluid, the mucoid fluid, it will not come out. Okay, so we do it in the anterior inferior quadrant. All right, now one more thing that you can do is you can insert a grommet. You can see over here, grommet is a small tube-like structure. So you see over here, I'm inserting this grommet in the tympanic membrane. This is the grommet. You can insert the grommet, and this grommet will keep the opening patent. Okay, so remember, laryngotomy and grommet insertion is done in the anterior inferior quadrant of the tympanic membrane, right? Okay, this is the grommet in the anterior inferior quadrant. Now this question is sometimes asked in the exam, identify the prosthesis. So you see, this is a grommet. This is how a grommet looks like after placing in the tympanic membrane. Okay, right? And this you can keep for few weeks or few months time. After that, there is no need to remove the grommet. Why? Because the grommet extrude, it comes out on its own. Because of the force of the healing tympanic membrane, it will throw out the grommet within a few weeks or few months time. So that depends upon the type of grommet. Okay, if the surface of the grommet is rough, that will stay for a longer time. If the surface is smooth, it will come out quickly. It will also depend upon the shape of the grommet. So we have different shapes of the grommet and we use them according to how much time we want to keep the grommet inside the tympanic membrane. Right? Okay, so that is the grommet in the anterior inferior quadrant of the tympanic membrane. Now, before we finish the topic, we have a principle that is known as Beer-Can principle. Sometimes what happens is that there is a very, very thick secretion. Okay, so now I give an incision over here in the anterior inferior quadrant, then I see that still there is no fluid coming out. Okay, because it's a very thick secretion. So you just like a beer can, you have to make another hole. The another hole is made in the beer can so that the air can go in. So now I give another incision in the anterior superior quadrant. Okay, so from this quadrant what happens? The air enters inside, and from the anterior inferior quadrant you see the fluid drains out. So this is known as Beer-Can principle. Sometimes we have to give two incisions in serous otitis media because the fluid may be very thick fluid so as to drain the fluid from the middle ear. Okay, so this is known as Beer-Can principle. Before we finish the topic of serous otitis media, I would like to discuss one more disease. Now this disease is the disease of actually eustachian tube dysfunction. We call it as aeroplane ear or otitic barotrauma. Okay, now what is this aeroplane ear or otitic barotrauma? You see, people who go in the flight. Now, when you go in the flight in aeroplane, now when you go up, now what happens? The pressure goes down, the air pressure goes down. Okay, so when you are at a height, the air pressure goes down. Now, nowadays we have the jets which are pressurized air jets. So you don't feel much change in the pressure. But if you go in a fighter plane, especially the older planes, and as you travel up, the air pressure goes down. So now the eustachian tube is functioning, and this eustachian tube equalizes the pressure with the outside atmospheric pressure. That means the middle ear air pressure also goes down. But if there is a rapid descent, now if there is a rapid descent of the aeroplane, now what happens? Okay, now the eustachian tube does not get the chance to equalize the pressure if there is a rapid descent. Okay, and in that case there may happen an injury to the middle ear that's known as aeroplane ear or otitic barotrauma. Okay, now remember, the aeroplane ear or the otitic barotrauma happens when there is a rapid descent from height, okay, such as in a aeroplane. Okay, so this is known as airplane or aeroplane ear. Now, this otitic barotrauma may also happen in case of sea divers. Okay, so number one, it happens in the aeroplane in a rapid descent. Okay, second, it can also happen in case of deep sea divers. So now, deep sea divers, what happens when they go down into the ocean? Now what happens? The outside atmospheric pressure is very high. The water pressure is very high. So the pressure in the middle ear equalizes and it also becomes high. Now if there is a rapid ascent in them, okay, once again the eustachian tube is not able to equalize the pressure, and what will happen because of that? Compared to the outside environment, the inside middle ear pressure will be very, very high. Okay, so I remember it like coming back to land. So when do we have otitic barotrauma? Coming back to land. So this is the question, this is the MCQ, otitic barotrauma or aeroplane ear, it is coming back to land. So when you are in the height, you come back, rapid descent in a plane. Sea diver, you are in the depth in the ocean, you come back to the land, rapid ascent. Okay, remember, aeroplane rapid descent, sea divers rapid ascent. Right? Okay, now because of that we have otitic barotrauma. Okay, so now let's see over here in the aeroplane ear, because of rapid descent what happens. if this pressure difference between the external environment and the middle ear becomes more than 90 millimeters of mercury, okay, more than 90 millimeters of mercury, if the pressure difference happens because of the rapid descent. Now what will happen? Because of this pressure difference, all the soft tissues around the eustachian tube opening in the middle ear, they are sucked in and they lead to locking of eustachian tube. Okay, so number one, as you can see over here, the soft tissues from the surrounding of the opening of the eustachian tube in the ear, in the middle ear, now they have all been sucked in and now there is locking of the eustachian tube. So now once the eustachian tube is locked, what will happen? The secretions of the middle ear, they will accumulate inside. Okay, so middle ear gets filled with fluid, and what will happen? This fluid will put pressure on the tympanic membrane, and what will happen? Tympanic membrane will become red, congested, and it will bulge. Okay, so red bulging tympanic membrane. Now how will the patient present to us? The patient presents to us with pain. So patient will have pain in the ear. Okay, patient will have fullness. Fullness means patient has hearing loss. Okay, now when you examine, what will you see? You will see the tympanic membrane, it is red, it is congested. Sometimes the pressure difference may be so much that there is a traumatic perforation of the tympanic membrane. The tympanic membrane may undergo a perforation. Okay, so these features are seen in otitic barotrauma. All right, now what is the treatment? The treatment is pretty simple. You have to give nasal decongestant drops. Okay, you can give this patient steam inhalation. You can and you can give this patient chewing exercises because they will move the soft palate and help the eustachian tube open. So you can advise chewing or swelling exercises. All right, most of these patients, they recover with this treatment. Sometimes if there's a lot of fluid collection, you may have to even do laryngotomy. Okay, right? So with this, the patient generally improve. But sometimes you may have to do laryngotomy. Now remember, this is generally a milder form of otitic barotrauma, which is seen in the aeroplane ear. That means the rapid descent. Now, the severe form is generally seen in case of rapid ascent. Why in the rapid ascent it is more severe? You see, in the rapid ascent, what is happening? There is a lot of positive pressure in the middle ear. Okay, so now there's a lot of positive pressure. This positive pressure may burst the tympanic membrane. It can even burst the round window. Now, if it bursts the round window, now what will happen? The perilimb will leak out. Okay, and now the patient may have vertigo, patient may have sensory hearing loss. All right, so all these problems may be present in rapid ascent after deep sea diving. Okay, so that's a more severe form of otitic barotrauma, and then you will have to treat the patients as per the symptoms of the patient. All right, okay, so that was a condition of eustachian tube dysfunction, right, known as otitic barotrauma or aeroplane ear. Now, before we finish the topic, let's come to this question. It was asked in the JIPMER November 2018. Barotraumatic otitis media is a result of rapid descent while in the aircraft. Yes, that's correct. So always remember, coming back to land. That is how, remember, in an aircraft, you come back to land, you have barotrauma. Sea diving, you come back to land. Rapid ascent, you have a trauma. Okay, rapid ascent, no. Sudden acceleration while in bus, sudden deceleration while in bus, that is also not correct. So answer is rapid descent while in an aircraft. Let us now discuss the chronic suppurative otitis media or chronic otitis media. Okay, so that means the chronic infection of the middle ear. Now, this infection may at times may even be associated with the pus formation. So we have the word suppurative. However, many times the pus formation is not there. Okay, so we prefer to use the word chronic otitis media nowadays, but once again, you can use these two terms interchangeably. Okay, so let's come to chronic otitis media or chronic suppurative otitis media. Now, this disease can be divided into two types. Which two types? Tubotympanic disease, TTD, and aticoenteral disease, AAD. Now, before I discuss these two different types of diseases, the first thing that we should know that what is the main problem in chronic suppurative otitis media. So, as we discussed in the acute otitis media, the permanent perforation. Okay, there is a permanent perforation, and this permanent perforation therefore leads to chronic otitis media. Okay, so before we go ahead, let's talk about this perforation. Shall we? Yes. So let's talk about the perforation. Now, perforation in the tympanic membrane can be at two places. It can be in pars tensa or it can be in pars flaccida. Right? Now, any perforation in pars flaccida is going to belong to aticoenteral disease. Right? Okay. Now, pars tensa perforation can be further divided into two types. Which two types? Central and marginal. So what do we mean by central and marginal? You see, any perforation that involves the tympanic annulus, also known as fibrous annulus. So any perforation of pars tensa that involves fibrous annulus. There is no fibrous annulus in pars flaccida. Okay, all perforations of pars flaccida, they are aticoenteral disease. Now, any perforation of pars tensa that involves this fibrous annulus, okay, this is known as marginal perforation. All right, and all marginal perforation, they belong to aticoenteral disease. All right, now the pars tensa perforation. What are central perforation? Central perforation means any perforation of pars tensa that does not involve the fibrous annulus. It's not necessary that the perforation has to be in the center. It just means that it does not involve the tympanic or the fibrous annulus. Okay, and all these perforations now are considered in tubotympanic disease. Okay, so tubotympanic disease, what do we have? We have central perforations. So when I say central perforation, it automatically means perforation of pars tensa. Right? Aticoenteral disease, what do we have? There is a perforation in pars flaccida or there is a marginal perforation. Right? Let's first talk about the tubotympanic disease. Okay, so let's talk about the tubotympanic disease. So tubotympanic disease, there is a central perforation. So I have shown you examples of different types of central perforation. So we'll talk about them. What is the problem to the patient because of these perforation? How will the patient present to us? What will be the history the patient will give? Now, how will a patient of tubotympanic disease present to us? What will he tell us in the history? Now, a patient of tubotympanic disease, now we know, has a central perforation. Now, because of this perforation, what will happen to patient? Patient will have hearing loss. Okay, what kind of hearing loss will that be? Patient comes to us with hearing loss, we examine, we'll find that this is a conductive hearing loss. Okay, how much conductive hearing loss will be there? The AB gap is 10 to 40 decibels. Okay, the AB gap is 10 to 40 decibels. That depends upon the size and the site of perforation. Remember, in tubotympanic disease, patient has chronic infection. Okay, now because of that, sometimes the ossicular chain may undergo necrosis. So if the ossicular chain undergoes erosion, then this AB gap will become around 45 decibels. Okay, or maybe a little more than that. All right, so it is 10 to 40 decibels if the only perforation is there. But if there is a tympanic membrane perforation and along with the ossicular chain breaks, okay, so ossicular chain erosion happens, then this hearing loss will be 45 decibels. Okay, now you know that the middle ear maintains an environment where the oxygen is less but the carbon dioxide is more. That does not allow the growth of bacteria. But now we have a perforation, so that function is lost. So what will happen? There will be infection. Because of infection, patient will have discharge from the ear, from the middle ear. Okay, so this patient will also complain of ear discharge. Okay, what kind of discharge? There will be a long standing history of discharge. All right, patient may say, since childhood I am having this problem. Now this discharge may be intermittent or continuous. Okay, sometimes the infection settles down, the discharge will stop. Again, the middle ear is exposed to the external environment, and again the discharge may start when there is a recurrent infection. Okay, now this discharge is coming from the mucosa, from the middle ear mucosa. So therefore, this discharge will be a mucoid discharge. If discharge is mixed with pus, it will be a mucopurulent discharge. All right, so it will always have a mucoid component because the discharge is coming from the mucosa. Now this discharge you see is a non-foul smelling discharge. The mucoid discharge especially is non-foul smelling. Okay. However, mucopurulent discharge at some times may be foul smelling. Okay. Now the most important thing to notice that discharge is coming from the mucosa. Okay, mucosa has a big surface area, not only on the middle ear, but the mucosa is there also on the mastoid ear cells. So because of that, there's a big surface area of the mucosa. And if the mucosa is giving discharge, the discharge will be copious in quantity. Large quantity discharge will be there. Okay, so this is the history that the patient of tubotympanic disease will provide. Now, tubo means tube, tympanic means middle ear. So this disease actually started, remember in the acute otitis media, there was a tubal occlusion. Because of that, infection came to the middle ear, and now there was a perforation in the tympanic membrane, which became a permanent perforation. So the disease started in the tube, came to the middle ear, settled down. Now there is a permanent perforation and long-standing infection. So the name is tubotympanic disease. Right? Nowadays, we also can name it as mucosal disease. Why? Because the discharge comes from the mucosa. Okay? If the discharge is coming, it is known as active mucosal disease. If the discharge is not coming, it is known as inactive mucosal disease. Okay? Remember, active mucosal disease may cause complications. Okay, inactive mucosal disease is unlikely to cause complications because the infection is not there. Okay, also tubotympanic disease was earlier known as safe CSM because it was thought that this will not cause complications, but this is wrong. Okay, the active mucosal disease has infection, it can cause complications. Okay, so we don't use the word safe or unsafe CSM nowadays. These terms have been discarded. We use tubotympanic disease, and you can also call it as mucosal disease. Right? Okay, what do you find on examination? On examination, you see a central perforation. Okay, look at this perforation. How do you say it's a perforation, which is a permanent perforation? Now you see this perforation will be circular or kidney shaped. Anything else? You will notice well-healed margins. Okay, these are the characteristics of a central perforation where there are well-healed margins. All right, that you can say it's a long-standing perforation. Okay, now let's look over here. This perforation can be further divided into a small perforation, that means involving only one quadrant. Okay, so we see over here only one quadrant is involved. All right, now if two quadrants are involved, that is known as medium perforation. So we can see over here this is a medium perforation, and if three quadrants are involved, it is known as large perforation. If all the four quadrants are involved, that is known as subtotal perforation. Okay, so this perforation is known as subtotal perforation. Now if this subtotal perforation also involves the fibrous annulus, that will be known as total perforation. Okay, so a subtotal perforation that also involves the fibrous annulus will be known as total perforation. Total perforation is not under central perforation. A total perforation becomes a marginal perforation. Remember, okay, so it is not in the classification of central perforation, it is not in tubotympanic disease. Okay, tubotympanic disease, we have central perforation, 4 types: small, medium, large, and subtotal. Okay, total belongs to eticoenteral disease. Am I clear? So now, before we go to the treatment of the tubotympanic disease, let us differentiate this perforation with other kinds of perforation, such as traumatic tympanic membrane perforation. Okay, so traumatic tympanic membrane perforation, what do you see over here? You can see the different perforations, different photographs that I have posted over here for you to see. Now, what do you see in them? The perforation, if you notice, is irregular. Okay, so this perforation is irregular in shape. Look at the margins of the perforation. You will see that these margins are rough, or I can use the word ragged. Okay, so they're not smooth, they're rough or ragged margins. Now you can also see blood or blood clots around the perforation. Okay, so these, they tell you that there is a perforation, right? Okay, which has been caused recently by a trauma. So we call it as traumatic tympanic membrane perforation. Okay, now the most common cause for this traumatic tympanic membrane perforation is the slap injury. Now you see, when you slap a person, usually your slap lands on the cheek of the person. Okay, and your fingers, they land on the pinna. But between the fingers, you know, there are some holes, so the pressure goes away. Okay, so the pressure will not go inside the EAC, and therefore the patient may not have traumatic tympanic membrane perforation. But suppose you slap and your palm of the hand, it lands on the pinna. Okay, so when the palm of the hand lands on the pinna, now what happens? All the pressure that is generated by this force, it goes in the EAC, and this pressure can cause a tympanic membrane perforation. That's a traumatic tympanic membrane perforation. Okay, now what will you do for this traumatic tympanic membrane perforation? Now remember, more than 90% of these perforation, they heal on their own. Okay, so most of this perforation, they heal on their own, so nothing has to be done. Okay, so this perforation with this will heal between next 3 to 6 weeks time on its own. Okay, so because they heal on its own, you don't have to do anything. Okay, your only thing that you have to do is wait and watch. All right, you can observe the patient, you will intervene only when this perforation will not heal on its own. We know even in acute otitis media, remember we studied acute otitis media, there is infection, still 90% of perforation heal. Okay, here there is no infection, so more than 90%, 90 to 95% perforations heal on their own. Okay, now a question is asked in the exam. Suppose a person has slapped another person, okay, and there is a traumatic tympanic membrane perforation. Now what kind of case will this second person slap on the other person? Will it be a grievous injury or will it be a simple injury? Okay, so for that, you have all studied forensic. You know that the grievous injury is described in section 320 IPC. And in the section 320 IPC, okay, the word uses permanent privation of either ear or hearing. Okay, the IPC has 8 clauses. Okay, so this IPC has 8 subclauses, and in one of the clause it is said permanent privation of either ear or hearing. So is this traumatic tympanic membrane perforation a permanent privation? No. In more than 95% patients, it heals on its own. Patient hearing comes back to normal. So this is not a permanent privation. Okay, therefore this is a simple injury. Don't get confused in the exam. This is a simple injury. Okay, if your opinion is asked, this is a simple injury, but the final opinion is given after 6 weeks. Because after 6 weeks, there may be a few cases. Out of 100, there may be 3, 4, 5 cases where this perforation does not heal. Okay, and if this perforation does not heal, then it will become a grievous injury. So the final opinion is given by the doctor after 6 weeks of observation, right? Okay, now next we come over here to this question. A patient after being slapped 3 days ago, so there is a slap injury and has been slapped 3 days ago, presents with decrease in hearing and no pain. Okay, so there is no pain now, there is decrease in hearing. The hearing is after the slap. Okay, following is the examination of the tympanic membrane. Now you see that there is a tympanic membrane perforation. Okay, what is the next line of treatment? Now many students were confused in this question because this perforation looks like a circular perforation. Now you see, you have to consider a few things. There is a definite history of slap. Okay, but this slap history was 3 days ago. So now what happens in 72 hours time? In 72 hours, 3 days, what has happened? The healing started. Okay, so the healing started. So the perforation may look like circular, but the significant thing is that the patient has decrease in hearing. So he specifically tells you that he has decrease in hearing after the slap. So you have to assume, you have to give this benefit of doubt that this perforation may be because of the slap. And now it has gone in the healing phase. So what will you do? You will wait for next 3 to 6 weeks time. Okay, you will wait and you will observe that whether this perforation heals on its own or not. If it heals, it was a traumatic tympanic membrane perforation. Okay, so what you have to do in this case is you have to wait and watch. Only after 3 to 6 weeks, if this perforation does not heal, then you will go for surgery. Okay, so tympanoplasty, meringoplasty is out right now. Antibiotics, there is no need, as you can see that there is no infection. Right? Okay, so that is what you see over here. The answer is wait and watch. Now, before we go to the treatment of the tubulotympanic disease, let us discuss one more topic over here, that is the tuberculosis of the middle ear. Okay, so tuberculosis of middle ear, this is also a chronic infection of the middle ear. And what happens in this tuberculosis? There is a chronic, painless and very, very foul smelling otorrhea. So once again, the patient comes to you with ear discharge. Okay, so you see over here, the presentation is again same, but this otorrhea is foul smelling. Okay, there is no pain. Just like the tubulotympanic disease also, there is no pain. Here also there is no pain. Okay, next, there are multiple perforations. So when you will examine the tympanic membrane, you will find more than one perforation. We call this like sieve-like tympanic membrane. Okay, so this is sieve-like tympanic membrane. You will see multiple perforations in the tympanic membrane. Then you may also see some granulations inside the middle ear. These are characteristically pale granulations. Okay, pale granulations inside the middle ear. The patient may also have severe hearing loss. So if you do an audiometry, you will find that if the patient has conductive hearing loss, it will be out of proportion to his symptoms. Okay, so his hearing loss is more than what he is complaining of, right? And then patient may also have sensory neural hearing loss. If there is sensory neural hearing loss, that means that the inner ear has also been involved by tuberculosis, right? Okay, and lastly, the patient may also develop facial nerve palsy. So the tuberculosis may spread facial nerve and patient may also have facial nerve palsy. Okay, now let's look over here in this diagram. This is a multiple perforation in the tympanic membrane known as sieve-like tympanic membrane, and this is seen in tuberculosis. Okay, now what else can we see? You see these are the multiple perforations. They are in the early stage of tuberculosis, and later on what can happen? it can form one big perforation. Okay, so you can see over here one large central perforation, and inside the middle ear you can see the pale granulations. Right? Look in this photograph also, you can see these pale granulations. Okay, so these are the characteristic features of tuberculosis of the middle ear. Right? And this question was asked recently in the NEET PG January 2020 exam. Tuberculosis otitis media of the middle ear has all of the following except multiple perforations are seen. Yes, they are seen. Pale granulomas are seen. Yes. ATT should be started. Yes, that is the treatment of choice. We have to give ATT. Painful otorrhea. No, this is painless otorrhea. So this over here is your answer over here. Okay, this is the wrong statement. So question was except the wrongful statement. Painful otorrhea is not seen. We see painless otorrhea. Okay, let us come to the treatment of tubotympanic disease. Okay, the tubotympanic disease, we also nowadays call it as mucosal disease. Now, calling it mucosal disease, okay, classifying it as active and inactive, not only this nomenclature is more appropriate pathologically, but it also helps us define the treatment as well as the possibilities of complications. Okay, so active means that there is a discharge, right? And therefore, we need to give antibiotics to this patient to stop the discharge. Okay, now once the active disease converts into inactive disease, okay, that means now we have a perforation but there is no discharge. Now we need to close the perforation. Okay, we need to repair the tympanic membrane, and the repair of tympanic membrane is known as laryngoplasty. Okay, repair of tympanic membrane is known as laryngoplasty. Now, over here, let's talk about laryngoplasty. Laryngoplasty, as I told you, is repair of tympanic membrane. But we know that this is a chronic disease. In chronic disease, not only there is a tympanic membrane perforation, but we can also have ossicular chain erosion. Okay, so if there is a ossicular erosion along with tympanic membrane perforation, that means you have to repair the entire thing. Okay, so then repairing only the tympanic membrane will not help. Okay, then we have to do tympanoplasty. Okay, tympanoplasty means repair of middle ear, tympanic cavity. Okay, so repair of middle ear, that is your tympanic cavity, that's known as tympanoplasty. Now please remember over here that laryngoplasty is a type of tympanoplasty. Laryngoplasty is repair of tympanic membrane. Okay, tympanoplasty is repair of the entire middle ear. That also includes the tympanic membrane. So laryngoplasty is actually a type of tympanoplasty. So if somebody asks you what is the treatment of choice for tubotympanic disease, so what answer will you mark? Your answer has to be tympanoplasty. Okay, because that term includes the term laryngoplasty. Right? Now this tympanoplasty can be of different types. Right? Let us discuss the types of tympanoplasty. All right, let's come to type 1 tympanoplasty. Now type 1 tympanoplasty is actually laryngoplasty. Okay, so this is what we have seen over here. Now we can see in this photograph, this is only the repair of tympanic membrane. So type 1 tympanoplasty or laryngoplasty. Now the question over here, how can we repair the tympanic membrane? Now what do we use to repair the tympanic membrane? Now the graft that we use to repair the tympanic membrane, most common graft is the temporalis fascia. Now this temporalis fascia is over the temporal muscle. Okay, this temporalis fascia is over the temporal muscle, and this is the most commonly used graft. Why? Because number one, it is available in the same incision. Okay, so in the same incision, you can harvest this fascia. and number two, that it has same consistency as the tympanic membrane. Okay, it has same consistency as tympanic membrane. So this is the most commonly used fascia or most commonly used graft for the repair of tympanic membrane. Now, other than temporalis fascia, we can also use some other grafts. So what all we can use? We can use perichondrium. Okay, now the best place to harvest the perichondrium is the tragus. So you use tragal perichondrium, right? You can even use tragal cartilage. Now cartilage is a thick graft. Okay, remember cartilage is a very thick graft, but this graft is used if we are having repeated failures. So you have done tympanoplasty 2 or 3 times earlier and still there is a failure, or there is a chance that this patient will fail. Okay, so the patient is in a risk factor. There can be multiple risk factors, such as patient is having cleft palate, eustachian tube is dysfunction. So in those cases, you can consider using a tragal cartilage. Okay, instead of using tragal cartilage, you can also use conchal cartilage. All right, because it is thick, so some people also make it thin. That means they slice the cartilage. That is known as sliced cartilage. Okay, so they make it thin, they slice it into a thin sheet and then they use it. So that's a sliced cartilage. So you can use this also. Some people have also tried vein graft. Okay, but remember the most commonly used graft is the temporalis fascia. All right, now this is type 1 tympanoplasty. Now let's look at this video. Okay, so we can see in this video now what is being done in this patient. You want to do a tympanoplasty. So this is the tympanic membrane. This is a normal tympanic membrane. Now there is a perforation in the tympanic membrane. So you want to repair this tympanic membrane. All right. So what you can do over here is you harvest the graft and then you raise the skin of the EAC along with tympanic membrane. This is known as tympanomeatal flap, and then you put the fascia below the tympanomeatal flap. Okay, so this is the most commonly used technique, that is known as underlay technique. Okay, so most commonly used technique for tympanoplasty or laryngoplasty is underlay technique. That means you put the fascia, okay, put the fascia medial to the fibrous annulus. So it is medial to actually the tympanic membrane. So what part? Medial to fibrous annulus. Right? So that is your underlay technique for doing the tympanoplasty. Okay. Now let's come to type 2 tympanoplasty. So when do we do type 2 tympanoplasty? When we have a tympanic membrane perforation and along with that there is ossicular chain erosion. Okay, so your ossicular chain erosion. Now, which is the most common site for erosion? We know the most common site for erosion is lenticular process of incus and followed by the long process. So now, what is done in this type 2 tympanoplasty? In this type 2 tympanoplasty, we repair the tympanic membrane perforation, we repair the ossicular chain and bring it back to its physiological position. Okay, so that means in a normal middle ear, the normal middle ear has two functions. The ossicles, they have two functions. Number one is aerial ratio and number two is lever ratio. So aerial ratio and lever ratio both are re-established. Okay, so we have a normal looking ossicular chain along with the tympanic membrane. Right, let's look in this. You can see over here that we have applied a fascia, a blue color fascia has been applied to repair the tympanic membrane. On the other side, you can see that if the lenticular process was eroded, so you can see that an implant has been applied from the long process of incus to the head of the stapes. Okay, so that's a K helix that has been applied. So you can apply different kinds of implants. So this is a K helix that has been applied over here so as to restore the ossicular chain. Let's look at this photograph. So this is the K helix. Okay, this is how it looks, and this is the intra-op photograph where you can see the ossicular chain is eroded. You can see over here, this is the long process of incus, and that's the stapes head. Okay, so this is the head of stapes, and that is the long process of incus, which you can see is eroded. Both the long process and the lenticular process are eroded. So there is a gap. So now to fill this gap, this K helix has been applied over here from long process to the stapes head. So that is your type 2 tympanoplasty. Okay, right? Now, let's come to type 3 tympanoplasty. Now you see over here, type 3 tympanoplasty is done when both malleus and incus, they are eroded. Okay, so both malleus and incus are eroded or they are involved in disease, and if they are involved in disease, we have removed them. All right, so only stapes is left. Right, so now when only stapes is left, now what you do is you put the graft directly on the stapes. So as you can see over here, you put the graft directly on the stapes. So now what happens? You have connected the tympanic membrane to stapes. Right? This is known as maringostepidiopexy. Right? Maringostepidiopexy. You have connected the tympanic membrane to stapes. Now you see over here, when the tympanic membrane will move, okay, when the tympanic membrane will move, it will transfer all the vibration to stapes, and stapes is like a column. Okay, it's a column, it will move like this. That is known as columella effect. What is columella? Columella is a central pillar. Sometimes buildings are built on one single pillar, central pillar, okay, that holds the whole building. That's known as columella, central pillar. So this moves like a central pillar. When the tympanic membrane will move, it will move like a central pillar. So this is known as columella effect. And all the vibration, all the sound vibration you see over here, they will go straight from here to the inner ear. Now you see over here, the surface area of the tympanic membrane is maintained. The surface area of stapes footplate is maintained. So in this type 3 tympanoplasty, we are able to still maintain the aerial ratio. Okay, so you see the aerial ratio, the ratio between the vibratory area of tympanic membrane and the footplate of stapes, that has been maintained. But if you notice over here, in this type of tympanoplasty, we have lost the liver ratio. Okay, there is no malleus, there is no incus, so the liver ratio has been lost in type 3 tympanoplasty. Okay, now this type of tympanoplasty, the type 3 tympanoplasty that I have just shown you, where you have directly placed the graft on the stapes head, this is actually known as type 3A tympanoplasty. Okay, type 3A tympanoplasty, the graft is directly on stapes head. Okay, so that is your type 3A tympanoplasty. Now we have a type 3B tympanoplasty. So now what you can do is that instead of putting the graft on the stapes head, what you can do is you can put an implant like this. Okay, so you can put an implant on the stapes head, and on this implant, what you can do is now you can put over here the graft like this. Okay, so if they put the graft like this, that will be known as type 3B tympanoplasty. And what we use in type 3B tympanoplasty, we use a PORP. Okay, PORP is an implant that is actually also known as partial ossicular reconstruction prosthesis. Okay, it's a short form for partial ossicular reconstruction prosthesis. So as you can see over here, an implant, a PORP has been placed over here between the stapes head and the tympanic membrane. Now once again, if you notice over here, with the help of this PORP, all the sound vibration is going from the tympanic membrane to the stapes. Okay, so once again we have the columella effect. Okay, so if you notice, once again we have the columella effect, and this is also known as maringostepidiopexy, because all the vibration of the tympanic membrane are going to the stapes. Okay, so this is again a type of maringostepidiopexy or columella effect, which is known as type 3B tympanoplasty, because we are using PORP. Now let's say the stapes suprastructure is also gone. Okay, that means the head, the neck, the two cruras, they are also gone. Now we know what is the last to remain. The last to remain is the footplate of stapes. Okay, so last ossicular chain, which part remains? The footplate of stapes. So now what you do in that? You can do type 3C tympanoplasty. So what we do in type 3 tympanoplasty? We put a TORP. What is TORP? TORP is total ossicular reconstruction prosthesis. Okay, so now you see in this diagram, now what we have done, we have placed this TORP from the footplate, all right. So you notice over here, from the footplate, you place this TORP to the tympanic membrane. All right, and once again, you see what is happening. This is a type of maryngostapediopexy. All vibration from the tympanic membrane will be going to the stapes footplate. Okay, so this is a type of maryngostapediopexy and a columella effect. You see, it's a single central pillar. The TORP is a single central pillar that will be vibrating when the tympanic membrane vibrates. Okay, so that is your type 3C tympanoplasty using a TORP. Right? Okay, let's come to type 4 tympanoplasty. Now, sometimes what happens? There is disease. Now, there is disease on the stapes footplate. Now, because of disease, you don't want to cover the footplate. Okay, so now what you do? You don't cover the footplate, you just cover the round window over here. All right, so what you have done is, you have just covered the round window. Now, what is the advantage of covering only the round window? You remember that the middle ear had two functions. Which two functions of the middle ear that we had discussed? Number one was amplification of sound. Okay, number one was amplification of sound. How many times? 22 times. So 22:1 was the ratio, the middle ear transformer ratio. Okay, so the sound had been multiplied 22 times. We also called it as ossicular coupling. That was the first function. Okay, what was the second function of the middle ear? The second function of the middle ear was acoustic coupling. So if you remember acoustic coupling, what was there? Now in acoustic coupling, when the oval window went in, the round window came out. So the two windows were vibrated in a phase difference. Right? Now what happens over here? Let's say both the windows are lying bare, there is no graft that has been placed. Okay, so now when no graft has been placed and you cannot cover the oval window, what happens? The sound reaches both the windows at the same time. Same sound, same intensity, same time, what will happen? It will push both the windows together and there will be no phase difference, and this force will cancel out each other. That means there will be no movement inside the inner ear. Okay, the two windows, they have started to cancel out each other. There will be no phase difference, there will be no sound in the inner ear. Now to create this phase difference, all right, what we can do is, you just cover the round window with the graft. So what will happen? The sound wave will first reach the oval window as usual. Okay, but the sound waves which is trying to reach the oval window is stopped by the graft. Now it is delayed by the graft. Okay, and this sound will reach the round window after a delay. This delay will create a phase difference between the two windows so that they are not cancelling each other and some sound goes into the inner ear. Okay, this is known as baffle effect. All right, this is known as baffle effect. Remember, in type 2 tympanoplasty, there is no aerial ratio, there is no lever ratio. We have lost the ossicular coupling. Okay, the entire ossicular coupling has been lost. We are only trying to maintain the acoustic coupling of sound. All right, so only this is being maintained in type 4 tympanoplasty. No amplification is being done by the middle ear. Okay, so now you see we have covered the oval window. Let's say there was a disease on the round window. So can I cover the round window? No, because there's a disease in the round window, I cannot cover. But in that case, can I cover the oval window? Yes. I can in that case cover the oval window, and we will call it as type 6 tympanoplasty. Okay, so you see over here type 6 tympanoplasty. So I said there is a disease on the round window. You don't want to cover it, you cover the oval window. So now what happens? The reverse happens. The sound first reaches the round window, and the sound which is reaching the oval window is delayed. So it reaches after some delay, and therefore again a phase difference is created. Okay, this is known as type 6 tympanoplasty, but over here you have done the reverse. Usually or physiologically, the sound always reaches oval window first. Okay, and then it reaches the round window. But over here, it will be reverse. The sound will be first reaching the round window, and then it will be reaching the oval window. So it is known as sono inversion. Okay, so remember type 6 tympanoplasty is also known as sono inversion. Okay, so now I remember, you see, very easy to remember, 4. If you reverse, this was the 4, the Roman number. If you reverse, it becomes 6. All right, so same way, what we are doing in 4, we are doing the reverse in 6. All right, so just remember like that. I also remember it like that. Now I know I've missed the type 5 tympanoplasty. So type 5 tympanoplasty is now obsolete. We don't do it anymore. Okay, now this type 5 tympanoplasty was earlier done for otosclerosis. So what was done in type 5 tympanoplasty? In type 5 tympanoplasty, we used to do a fenestration operation. So this is the other name for fenestration operation. So what is done in this? A fistula was created on the lateral semicircular canal. Okay, you see what happened in otosclerosis. We will be discussing otosclerosis future also. The oval window was fixed. So a second window was needed to transfer the sound to the inner ear. You know, inner ear requires 2 windows. So one window, the otosclerosis, one window, oval window is gone. So another window was needed because you need 2 windows, only round window was working. So another window in the form of a fistula was created in the lateral semicircular canal, and then the graft was placed over it. Okay, so that's known as type 5 tympanoplasty, also known as fenestration operation, done for otosclerosis, and it is an obsolete procedure not done nowadays. Okay, so these were the different types of tympanoplasty. Let's come to this question. Columella effect is seen in which type of tympanoplasty? So as we just discussed, it is seen in type 3 tympanoplasty, also known as maringostepidiopexy. All right, so that was tuberotympanic disease and its treatment. Let us now come to eticoenteral disease. All right, what is so special about this eticoenteral disease that we have separated it out? And the special thing about the eticoenteral disease is presence of cholesteatoma. Okay, so this term cholesteatoma we have been hearing since the anatomy. What is this cholesteatoma? Cholesteatoma is normal cretinizing stratified squamous epithelium. So cretinizing stratified squamous epithelium, that is your skin. So if it is the normal epithelium, what is the problem? The problem is that this skin, this squamous epithelium is in a wrong place. So which place is it? It is in middle ear cleft. Okay, middle ear cleft. Now you see, the middle ear cleft we know is formed from first pouch. Remember, tuberotympanic recess. So that is your endoderm. Okay, this is your endoderm. Now, this cretinizing stratified squamous epithelium means this is ectoderm. So how can ectoderm reach into a place that is formed by endoderm? How can it reach? Now, based upon that, this cholesteatoma can be classified into congenital or acquired. Okay, so what is the congenital cholesteatoma? Now, this was proposed by McKinsey. All right, congenital cholesteatoma. What is a congenital cholesteatoma? Congenital cholesteatoma means some epithelium gets trapped in the middle ear during the formation of middle ear. So that means some ectoderm is trapped inside during the formation of middle ear, and that forms congenital cholestoma. Okay, how do you say that this cholestoma is congenital? How do you say? Okay, so for a cholestoma to be called as congenital, number one, how does it present? You see, this presents as a white pearly mass behind an intact tympanic membrane. Okay, so this congenital cholestoma, we will consider it congenital if it's a white pearly mass behind an intact tympanic membrane. So if the tympanic membrane is not intact, you cannot call it as congenital. Anything else? Yes. The second condition is that there should be no history of tympanic membrane perforation or any surgery. Okay, middle ear surgery, tympanic membrane surgery. Okay, so there should be no history of tympanic membrane perforation or middle ear or tympanic membrane surgery. All right, then you can call this white pearly mass as congenital cholestoma. All right, so now we know how the congenital cholestoma looks like. You can see over here, this is a small cholestoma and this over here is a big cholestoma. Both are behind an intact tympanic membrane. Okay, now the cholestoma can be acquired. Okay, acquired cholestoma can be further of two types. Which two types? It can be primary acquired and secondary acquired. Now, what do we mean by primary acquired and secondary acquired? You see, secondary acquired means secondary to perforation. So there has to be a tympanic membrane perforation. Okay, so now there are different theories for the formation of secondary acquired cholestoma. Number one, squamous metaplasia. So what happens? There is a tympanic membrane perforation. Because of this perforation, there is dryness, there is repeated infection. Okay, so the middle ear mucosa changes to squamous epithelium. Right, that is known as squamous metaplasia. Right, now second thing that can happen is there is a marginal perforation. Remember, marginal perforation we considered in the aticoantral disease. So what happens if there is a marginal perforation? If there is a marginal perforation, we know the annulus is gone. Okay, so what is lost? The fibrous annulus is gone. The annulus, it acts as a barrier. You see, outside the tympanic membrane, in the EAC, we have the chitinizing stratified squamous epithelium. Inside, on the medial side, we have the middle ear mucosa. Now, this annulus does not allow the skin from the EAC to grow into the middle ear. But if we have a marginal perforation, so what can happen? If there is a marginal perforation, the skin of the EAC starts growing into the middle ear. That's known as theory of invasion. Okay, so that means the EAC skin invades into the middle ear, okay, and forms cholestoma. There it will be known as cholestoma. Okay, so that was your secondary acquired cholestoma. Now, let's look over here at this theory of invasion over here. You can see that the EAC skin is invading into the middle ear. You can see it is growing into the middle ear after a marginal perforation. Okay, so we can see that this is a marginal perforation. The posterior superior layer annulus is gone, okay, and the EAC skin is going into the middle ear. So this is theory of invasion, inwards migration of the epithelium. Okay, here also you can see that the epithelium has migrated inside. Right? Okay, next we come to the primary acquired cholestoma. Now, primary acquired cholestoma, we have different theories. The most accepted theory is the theory of invagination or Whitmark's retraction pocket theory. This is the most important theory we have to study, theory of invagination or Whitmark's retraction pocket theory. Okay, other than this, we have some other theories also, such as Sardis, squamous metaplasia, or basal cell hyperplasia given by Rudy. So we'll study these theories also. Okay, so let's first start the theory of invagination. Now, before I study this theory, let us revise the anatomy of the middle ear. So remember, this is the photograph of the middle ear. What can we see in this photograph? Okay, let's identify the structures. This is the tympanic membrane. Okay, this is the malleus. Now, malleus, we have a head. There is a neck. Okay, and then what is this? This over here, this is the lateral process of malleus. Okay, this is the handle of malleus. Now the important point over here, the lateral process of malleus, it divides the tympanic membrane into two parts. Which two parts? We have the pars tensa and we have the pars flaccida. Okay, so this part over here, this is known as pars flaccida, also known as shrapnel's membrane. Right? Now remember this bone over here, the lateral bony wall of attic, that's known as scutum. So if I take this scutum, I take the pars flaccida, I take the lateral process of malleus, this over here is the neck of malleus. Now we can see that there is a ligament of malleus that's known as lateral ligament of malleus. Okay, so that's known as lateral ligament of malleus, and you see in between them there is a space. So if I join them all, and this space is known as Prusak space. Okay, this space is known as Prusak space. What are the boundaries of Prusak space? Let's revise the boundaries of Prusak space. So what are the boundaries of Prusak space? Now what is the superior boundary? You see the superior boundary is lateral ligament of malleus. Okay, what is the medial boundary? We saw the superior boundary. The medial boundary over here is the neck of malleus. Right? What is the inferior boundary? The inferior boundary is the lateral process of malleus. Right? Lateral process of malleus. Okay, and now we have the lateral boundary. The lateral boundary is by pars flaccida and the scutum. So in between them we have this Prusak space. Right? What is the significance of Prusak space? Prusak space is the most common site for formation of primary acquired cholesteatoma. Okay, most common site for formation of primary acquired cholesteatoma. Now we have understood this anatomy. Let's look at this middle ear. Okay, so I'll erase all this. Let's come back to the middle ear diagram. Now remember acute otitis media. Stage 1. What happens in stage 1? There is a negative pressure. Okay, so let's say we have a situation, your suction tube is blocked, it is not working completely, there is a negative pressure in the middle ear. Okay, what will happen because of this? The tympanic membrane is retracted, it is pulled in. Which part of tympanic membrane will show maximum retraction? Of course, the pars flaccida. Why? Because there is very less fibrous layer. Okay, so what happens? This pars flaccida, it gets retracted inside and it forms a retraction pocket. Right? Okay, so there is formation of retraction pocket. Remember, this retraction pocket has mainly two layers. Which two layers? It has a mucosal layer, and inside the pocket, that means the lateral side or the inside of the pocket, we have the epithelial layer. Okay, now you know, repeated retraction of the tympanic membrane, repeated formation of the retraction pocket with negative pressure. So after some time, what happens? The retraction pocket gets adherent. Okay, it sticks to the malleus, to the neck of the malleus. So as you see over here, now it becomes adherent. It will not go back. So even if the pressure is re-established, okay, so this pocket remains inside. Now what happens because of that? Now the pocket from inside is lined by epithelium, squamous epithelium. The squamous epithelium has a property. Which property? The more epithelium, the new tissue grows from the basement membrane. The old cells, they are shed off from the surface. Okay, so the old dead cells, they are shed off from the surface, and this dead tissue gets collected inside the pocket. All right, so this dead tissue is collected inside the pocket. Now what will happen? Dead tissue is good for infection. Okay, so the infection, the bacteria comes from outside. It is open to the outside atmosphere, and this bacteria comes from outside. There is formation of pus. Pus means pressure. Now, to accommodate this pressure, what will happen? The pocket will start growing in size. Okay, so this pocket starts growing in size. Okay, now more the size of the pocket, what will happen? More epithelium is shed off. Right? More epithelium is shed off, what will happen? More will be the pus formation. Okay, so you see, more will be the pus formation, and therefore, what will happen? More will be the pressure and more will be the need to grow. So this pocket needs to grow further. What will it do? It will start eroding the surrounding bones. Okay, it starts eroding the surrounding bones and it occupies the entire attic. So as you see over here, it occupies the entire attic. Okay, you see over here, it has eroded the scutum. So remember, in the anatomy of middle ear, I told you that erosion of scutum. This erosion of scutum, it's a characteristic CT scan finding in cholesteatoma. There I also told you which type of cholesteatoma, primary acquired cholesteatoma. Okay, so now this cholesteatoma has involved the entire middle ear. It has also eroded the malleus and the incus, especially the head of the malleus, the body and short process of incus. So it has occupied the entire attic. Right? Now it needs more space. We know the more it grows, the more space it requires. So what will it do? Now attic is connected to antrum through the adytus. So what will it do? It goes to the antrum via the adytus. Okay, remember what this disease is named? So this disease is also named as atticoantral disease. So attic is involved, antrum is also involved. Right? Now what do we have? Now we have a sac-like structure. What does this sac-like structure contains? It contains keratinizing stratified squamous epithelium inside the middle ear cleft. Okay, this is known as primary acquired cholesteatoma. So a primary acquired cholesteatoma forms in a retraction pocket, Whitmack's retraction pocket theory. Okay, most common site for formation of the retraction pocket is the Prusac space. So therefore, Prusac space is the most common site for formation of primary acquired cholesteatoma. All right. Okay. So that was the Whitmack's retraction pocket theory. Let's look over here. What happens in this retraction pocket? There is formation of a retraction pocket. It grows and it starts forming the cholesteatoma because of the epithelium. Okay. Next, this is also known as theory of invagination. Okay, Whitmack's retraction pocket theory or theory of invagination. All right. Now, other than this, we also discuss some more theories such as basal cell hyperplasia. So there is a hypothesis that there are some cells, the basement membrane cells, on the pars flaccida, they start growing. There is a hyperplasia of those cells. And then they grow and then they form the cholesteatoma. Okay, so that is your basal cell hyperplasia theory. The third theory is the primary squamous metaplasia, that the mucosa inside the middle ear, especially the attic, it undergoes metaplasia, okay, primary without any perforation and forms the cholesteatoma. Okay, but we know that the most accepted theory is the Whitmack's retraction pocket theory for formation of primary acquired cholesteatoma. All right. Okay. So let's look over here. This is a primary acquired cholesteatoma. It engulfs the malleus and the incus and erodes them, and the patient will complain of hearing loss. Okay. So look over here. This cholesteatoma, it engulfs. It starts from here, but it engulfs the malleus and incus. So obviously, patient is going to have conductive hearing loss. Okay. Right. Now, before we go ahead, let us discuss a small topic on the retractions of the tympanic membrane. So we'll discuss the retraction of pars flaccida or the attic. Okay, so now the grades of retraction, you look over here, this is a normal pars flaccida over here. So you can see over here, this is a normal pars flaccida. right? And now there is a small retraction. So this is a very small retraction, but yet it is not become adherent to the neck of malleus. Okay, so grade 1, there is a retraction pocket, but it is not adherent to the neck of malleus. Grade 2, it becomes adherent to the neck of malleus. So as you can see over here, it becomes adherent to the neck of malleus. Right? Now, in grade 3, you see, grade 3, you cannot see the complete retraction pocket. Right? You cannot see the complete retraction pocket, and there is some erosion of the scutum. Okay? So grade 3 retraction pocket, we see there is a mild erosion of the scutum. And grade 4, there is a major erosion of the scutum, and you cannot see the pocket. There may even be formation of colostoma inside the pocket. Okay, so these are grades of pars flaccida or the attic retraction. Okay, now let's look at a few photographs over here. This is the photograph of the retraction of the pars flaccida, where the retraction pocket you see over here has become adherent to the neck of the malleus. Okay, so this is your grade 2 retraction pocket, right? And this over here you can see is a grade 4 retraction pocket. What you see over here, that there is a major erosion of the scutum. You see over here, all the scutum is eroded. All right, you can see the pocket going in. You can see some white flakes over here. Those are colostoma flakes. Okay, so that is actually now the formation of the colostoma. That's a primary acquired colostoma in a attic retraction pocket. This over here also you can see that all this scutum is eroded. Okay, and you can see the epithelium going in. So that is a grade 4 retraction pocket. All right. Now, similarly, we can also have retractions of pars tensa. So the retraction of pars tensa, the grading was done by Sade. So this is known as Sade's grading for the pars tensa retraction. So now what is the grading? Grade 1. Now grade 1 we have already discussed. Grade 1, there is a mild retraction of the tympanic membrane. Now what happens in this? The tympanic membrane becomes dull, lusterless, okay, non-shiny. What else? The cone of light. The cone of light, either it is absent or it is distorted. Right? Cone of light is absent or distorted. Anything else we can see, the handle of malleus is pulled inside. So because the handle of malleus is pulled inside, this handle of malleus, you can see over here, this is said to be foreshortened. Okay, so you can see that this is foreshortened over here, the handle of malleus. It's not shortened, it's pulled inside, so it rotates, so it is foreshortened. Okay, and because of that, because of the retraction, the anterior malleolar fold and the posterior malleolar fold, you see this is the anterior, this is the posterior, both of them they become more prominent. Okay, so anterior and posterior malleolar folds, they become more prominent. All right, these are the two folds that along with the lateral process of malleus, they separate the pars tensa from the pars flaccida. So because the tensa is retracted, so they become more prominent, right? So that's your grade 1 retraction. Now what is a grade 2 retraction? Now grade 2 retraction, what happens? The tympanic membrane is retracted inside and it goes and it becomes adherent to the incus and stapes joint, okay, to the IS joint. So we can see the long process of incus, okay, or you can see along with it the stapes head. So you see over here in this photograph, the long process of incus has started becoming visible because the tympanic membrane is retracted and it is now adherent to the IS joint. Okay, that's your grade 2 retraction. Now the grade 3 retraction, you see over here, the tympanic membrane has gone and retracted till the promontory, medial wall of middle ear. But if I do a Siegel speculum examination, okay, so if I do Siegelization, if I create some negative pressure inside the EAC. Now what will happen? The tympanic membrane will move out. So that means it is not fibrous, it is not adherent to it. It is just lying next to the promontory. Okay, so it is not adherent to the promontory. It is just lying next. Tympanic membrane is still mobile. You can still move the tympanic membrane on signalization. All right. Grade 4 retraction is that the tympanic membrane has become adherent to promontory. Right? So as if it is pasted because of the fibrosis. So there may happen some fibrosis between the tympanic membrane and the medial wall of middle ear, the promontory, and now on signalization, the tympanic membrane will not move. So that is your type or grade 4 retraction of the pars tensa. All right. Now we can also have a posterior superior retraction pocket. You see the pars tensa, posterior superior part. Okay, this posterior superior quadrant or the posterior superior part, it can form a retraction pocket. So as you can see over here, this can form a retraction pocket, and this retraction pocket goes up posterior superiorly, eroding the stapes or the incus, and it can also form cholestoma. Okay, so this is also known to form primary acquired cholestoma. This is one of the important sites for formation of primary acquired cholestoma. Right? Okay, now that brings us to the symptomatology of aticoantral disease. How will this aticoantral disease patient present to us? So now we have understood the pathophysiology of the aticoantral disease. Let's look at the symptomatology. What is the problem with the patient? Hearing loss. As I told you, the ossicular chain is eroded by the cholestoma, so the patient presents to you with hearing loss. What kind of hearing loss? Once again, this is going to be conductive hearing loss. Okay, right? The AB gap is usually around 45 decibels. There is erosion of the ossicular chain. Right? Now remember, this aticoantral disease patient may also have sensory neural hearing loss. Why sensory hearing loss? Because the toxins which may be released from the retraction pocket, you see the retraction pocket has dead epithelium, plus there is bacteria. So because of that, there is toxins. These toxins may be released from the retraction pocket and they may go to the middle ear. From the middle ear through the round window, they can enter into inner ear and can cause sensory neural hearing loss. Right? So aticoantral disease patients may also have sensory neural hearing loss along with conductive hearing loss. Okay. Next, the patient can also complain of ear discharge. Okay. So you see hearing loss, ear discharge, both the complaints are also seen in tubotympanic disease. Now, how can we differentiate between them? The main differentiating feature is the ear discharge. How? The ear discharge once again has a long-standing history of ear discharge. Now, again, it can be an intermittent or a continuous discharge. This discharge is purulent. See the difference? The discharge is coming from the retraction pocket. That retraction pocket is lined by squamous epithelium. So there will be no mucoid component to this discharge. It will be a purulent discharge. Okay, so very important. If somebody says purulent discharge, it cannot be tubotympanic disease. Tubotympanic disease is mucosal discharge. This is coming from the squamous tissue. Right? Okay, the discharge is foul smelling, or it can even be blood stained. Why? Because there is a lot of bony erosion. Remember, this pocket needs space, so it erodes the surrounding bone. So because of the bony erosion, there is discharge is extremely foul smelling discharge, may even be blood stained discharge. Okay, anything else? Yes, the discharge is coming from the pocket. The pocket has a comparatively small area to begin with. The surface area of the inside of the pocket is small. So this discharge is usually scanty in quantity. Sometimes the patient may not even notice the discharge because the discharge dries up inside the EAC. So that is also possible. Patient may come to you with only complaint of hearing loss. Okay, yes, never notice the discharge because the discharge dries up inside the EAC. So discharge is scanty in quantity, right? Okay, now see this discharge in etiquantral disease is coming from the squamous tissue. Therefore, the etiquantral disease is now also known as squamous disease. Once again, if the discharge is coming, it is active squamous disease. If the discharge is not coming, it is known as inactive squamous disease. Now, this classification, once again, it helps us in two ways. Which way? We know active squamous disease is infected, therefore, this is more likely to cause complications. Okay. Secondly, active will need a different kind of management as compared to inactive. You see, inactive, there is no discharge. Sometimes we may have a very shallow pocket with no discharge, inactive disease. You may not require any treatment. Okay, whereas active will require prompt treatment to prevent the complications. Okay, so this classification, squamous, active, inactive, it helps us gauge which disease, which case will have more complication and what kind of treatment, how soon the treatment is required for the patient. Okay, so now let's look at these photographs. These are all photographs that I'm once again showing you. When you examine the patient, this is what you will see in this patient of primary acquired cholestoma. Okay, so now remember, primary acquired cholestoma, the problem is usually in the attic. Okay, the problem is in the attic, in the pars flaccida. So look, in this first photograph, you will see that there is erosion of scutum. The pars tensa, however, is normal. Only in the pars tensa you will see the erosion of scutum is there. There is epithelium going in. You can see that black color debris. Okay, so that is your cholestoma. Right? Now look in the second photograph. You can once again see that the pars tensa is normal. Right? But pars flaccida, you can see that there is an erosion of the scutum. The epithelium has gone in. You can see these white flakes. These are the cholestoma flakes. Sometimes you can also see black color debris. That's the necrotic dead tissue debris over there. Okay. Then you see over here in the third one, you can see that once again the pars tensa is normal and the pars flaccida, you can see over here in that attic there is a retraction pocket, there is a scutum erosion. In the fourth diagram that I have kept over here, you can see that there is a posterior superior retraction pocket. So this is a posterior superior retraction pocket. Now you can see, now you see, before I go ahead, you understand why I am calling it as a retraction pocket and why not as a perforation. So many students, they get confused. Actually, it does not matter for the management. See, if you are not able to understand whether this is a perforation or a retraction pocket, just notice one thing. Let me believe that it's a perforation. Okay. Now you see, if I say it's a perforation, still you will see that these margin, the posterior superior margin, are gone. It's a marginal perforation. Okay, so marginal perforation once again will be etiquantral disease and will be cholestoma. Okay, although we will call it as secondary acquired cholestoma, but it will still be cholestoma. The management will still be the same. All right. Okay. Now, if I say it's a posterior superior retraction pocket, it will become a primary acquired cholestoma. Now, why I'm saying it's a retraction pocket? I'm saying it's a retraction pocket because if you look inside, you can see the reflection of light. Okay, this reflection of light is by the epithelium. So I'm saying the pocket has gone in. But still, the examiner will give you benefit of doubt. Why? Because the main criteria is you have to use the Siegel speculum, and with that you have to do Siegelization and you have to move the epithelium. So once you do Siegelization, you will see that the walls of this pocket will move. So that will make it clear, which is not possible in just by looking at the picture. So if you say it's not a retraction pocket, it's a marginal perforation, the examiner will still give you full marks. In fact, this question was asked in the exam. Okay, and over there, the answer that they just wanted was acquired cholestoma. Okay, this diagram was there in the exam. They just wanted you to tell it is acquired cholestoma. They didn't want you to differentiate between primary acquired or secondary acquired. Primary acquired will be in the retraction pocket, the secondary acquired will be in the perforation. If you just tell them it's a acquired cholestoma, even that is all right. Okay, but in this case, this question is also an exam question. This image was asked in the exams recently. Okay, there also the examiner gave the leniency and asked that this finding is seen whether it's a cholestoma, okay, it's a congenital cholestoma or a acquired cholestoma. He didn't ask it's a primary acquired or secondary acquired, but the examiner can ask. It's a typical scenario where we have a attic retraction pocket, okay, so it's a primary acquired cholestoma. That you should not make a mistake. Okay, in a posterior superior retraction pocket, if you are not able to differentiate without signalization, that is all right. Still, I am giving you a hint that if you see inside this, there is a light reflecting back, so it is more likely to be a retraction pocket. Okay, now let's look at this question. My point will become clear. So this question was asked in the NEET PG January 2019. Identify the disease in the picture shown below. So as I was telling you, this is an exam picture. It was asked in the exam. You can see that the pars tensa is normal, but in the pars flaccida, the sputum is eroded. There's a retraction pocket. You see these white color cholestoma epithelial flakes. So what is this? Is this keratosis obturans? Keratosis obturans, tympanic membrane will not be visible. Simple. It is not keratosis obturans. Okay. Is it a congenital cholestoma? Congenital cholestoma, there will be no erosion of the sputum. Right? There will be an intact tympanic membrane. The epithelium is behind the tympanic membrane as a white pearly mass. So what is this? This is acquired cholestoma. Which type? Primary acquired cholestoma. It is of course not a tumor, not a osteoma. Okay, so answer was acquired cholestoma. In this type of question, examiner can further ask, it is a primary acquired or a secondary acquired, and I expect my students to know that this is a primary acquired cholestoma. Okay, a secondary is secondary to perforation. There is no perforation over here. What was earlier believed as a perforation in the pars flaccida, now we know it is usually a retraction pocket. Looks like a perforation, but it's actually a retraction pocket in the pars flaccida. Right? Okay, let's go to the management of atiquantral disease. Now the management, the treatment of choice for atiquantral disease is modified radical mastoidectomy. Modified radical mastoidectomy. Right? Now, before I make you understand what is modified radical mastoidectomy, let's talk about mastoidectomy. What is mastoidectomy? What are the different types? There are three different types of mastoidectomy. So let's talk about the three different types. Okay, number one, we have the simple or cortical or Schwartz mastoidectomy. This is the first type. Now, what we do in this? Look at this diagram. We have already studied this diagram. I already explained this in the anatomy. So, what have we done in this diagram? In this diagram, we have removed all the air cells of mastoid. Remember, I told you, you remove all the air cells of mastoid, that is cortical or simple or Schwartz mastoidectomy. So, when you remove all the air cells of the mastoid, okay, without touching the middle ear, that is simple or cortical or Schwartz mastoidectomy. Now, where all do we do Schwartz mastoidectomy? Number one, when the disease is only in the mastoid. Okay, so which I have already told you that also in coalescent mastoiditis. Okay, which was earlier known as surgical mastoiditis, but we don't do that much surgery nowadays in coalescent mastoiditis. Anything else? In cochlear implant, remember this is the step one for cochlear implant. You do a cortical mastodectomy, then you make a hole in the facial recess area, that's known as posterior tympanotomy. You enter into the middle ear, and then you make a hole in the cochlea near the round window, that's known as cochleostomy. Okay, and you enter into the cochlea, that's known as cochlear implant. All right, so we will study cochlear implant. So cortical mastodectomy is done for cochlear implant. Now let's look the small video of the simple or cortical or Schwartz mastectomy. So what we do in this, you give an incision behind the ear. Okay, so behind the pinna, you give the incision on the mastoid process. You cut the skin, you reach the bone. So now what you do is you start drilling the bone. Now where will you start drilling? At the McEwen's triangle. You see the McEwen's triangle. You start drilling the bone. You remove the ear cells, right? You start removing the air cells and you start identifying the landmarks. So what are your landmarks? When you go inside, what landmarks will you identify? Okay, you have opened the antrum over here, you can see the lateral semicircular canal. Remember I told you the lateral semicircular forms the medial, is the bulge is seen in the medial wall of the antrum. Then there is tegmen. Above the tegmen, we have the brain. Posterior boundary is formed by the sinus plate, the sigmoid sinus. Okay, we can see the chorda tympani and the facial nerve in the anterior wall of the mastoid. Remember, this is the vertical or the mastoid segment, and the middle ear ossicles are also visible through the adductus. Okay, so you can see the facial nerve, the chorda tympani. This is the cortical mastectomy. This is the end point for cortical mastectomy when you are able to see these structures. You have removed all the air cells and you are able to see all these structures. That is the end point for cortical or simple or Schwartz mastectomy. All right, let's come to radical mastectomy. What is radical mastectomy? Now look in this photograph. We have also seen this photograph earlier. What has been done in this? In this, the mastoid and the middle ear, they have been combined together and a common cavity has been created. Okay, so as you can see over here, the common cavity has been created. How the common cavity has been created? By removing the common wall. The common wall means the posterior wall of middle ear. Okay, so you remove the posterior wall of middle ear, do a radical mastectomy, remove all the ear cells of the mastoid. Okay, you open the middle ear, remove the posterior wall of middle ear. Now remember, in the posterior wall of the middle ear, we have one important structure, which is that we have the facial nerve. Okay, so you see over here we have this facial nerve. Now remember, once you are removing the posterior wall of the middle ear, you should not damage the facial nerve, otherwise the patient will have facial palsy. So this is the most important challenge while doing the radical mastectomy or any kind of mastectomy, that you should not damage the facial nerve. So I have highlighted the facial nerve over here for you, right? Okay, so remember, do not damage the facial nerve. Okay, the most common iatrogenic means during treatment, iatrogenic cause of facial palsy is mastoidectomy. Okay, the most common iatrogenic cause for facial palsy is mastoidectomy. Okay, mastoidectomy, all the three together included. Okay, so you are removing the posterior wall, you have to save this facial nerve. Now that is step one. What else do we do? Other than removing the posterior wall, you have made a common cavity. Now you see, you also remove the conductive apparatus of sound. So what do I mean by conductive apparatus? The conductive apparatus means the tympanic membrane and the ossicles. Okay, so you remove the conductive apparatus. You remove the tympanic membrane, you remove the malleus, you remove the incus, okay, but you do not remove the stapes. Look over here in this diagram, you can see over here that we still have the stapes. Now why I am not removing the stapes over here? Because if I remove the stapes, remember the foot plate is on the oval window. So if I remove the stapes, the perilymph will come out. Now perilymph is same as CSF. So when the perilymph comes out, patient will have sensorineural hearing loss, patient will have vertigo, okay, and patient can even have meningitis. That's brain infection. Meningitis can lead to death of the patient. Okay, it's a serious infection. So now you don't want that. You don't want to create more complications. Okay, so you will not remove the stapes. Okay, so this is how we do radical mastectomy. Now, why we are doing radical mastectomy? What is our aim in radical mastectomy? The aim in radical mastectomy is complete eradication of disease. Okay, complete eradication of disease. You don't care for the hearing. Which type of hearing? Conductive hearing. The sensorineural hearing is from the cochlea and the nerves. That you don't disturb. But you don't care about the conductive hearing. Your aim is complete eradication of disease. Right? Okay, so now where do we do radical mastectomy? Okay, now before we go to the indications, let's watch this small video. So remember the previous video, we had done the cortical mastectomy. So this was the end point of cortical mastectomy that we had seen. Now from here, we can continue ahead and we can do a radical mastectomy. So let's look over here that this video, you can see the facial nerve, you can see the middle ear ossicles. So now what we do is we remove the wall. Which wall? Okay, we remove the posterior wall of the middle ear. So you can see that more drilling is being done. The attic is visible, the canal is visible, the ossicles are visible now. You can see the round window. Okay, so all this is possible when you start removing the posterior wall. So let's say there is a tumor, there is a malignancy, or there is a clostoma over here. So what you do is you remove this wall. So this you can see the posterior wall is removed, the tympanic membrane is there, that also you remove. Okay, so you remove all these structures, the tympanic membrane, the malleus, the incus, and you create a big common cavity. So that is your radical mastectomy. Now, what are the indications of radical mastectomy? Indications, number one, there is malignancy, carcinoma of the middle ear. Okay, there is a tumor like glomus tumor, most common benign tumor of middle ear, glomus tumor. Okay, now sometimes you want to reach into the petrous part of temporal bone. There also you have to drill and open the middle ear and the mastoid. There is a tumor in the petrous part, so you can use this as an approach to the petrous part of temporal bone. Okay, number four, there can be a cholestoma, which is going into the eustachian tube or into the round window niche or into the perilabyrinthine, around the labyrinth or the hypotympanic cells, which you are not able to remove. In those cases also, you may have to do radical mastectomy, right? And finally, number five, repeated recurrence of cholestoma. Okay, remember I told you cholestoma, attic-ventral disease, you do what? Modified radical mastectomy. Okay, so you do modified radical mastectomy, but if we have done it, there is still repeated recurrence, you may have to go and do radical mastectomy. Okay, so now remember, whenever we do radical mastectomy, you see, we also have to do one more surgery, that is meatoplasty. What is meatoplasty? I've already told you, meatoplasty is surgery of the cartilaginous part of ears. You see, inside the cavity becomes big, but the outside, the meatus, the meatal opening, if it remains small, what will happen? All the debris, okay, the dead tissue, they will accumulate inside the mastoid and the middle ear, the common cavity. Okay, so now to keep the cavity dry so that there is no growth of bacteria, to remove all this debris, we have to increase the size of the meatus. We have to widen the cartilaginous part of EAC, so that is known as meatoplasty. Okay, so meatoplasty is always done when you do a radical mastectomy. So we can do meatoplasty in different ways. So as you see over here, incision is given at the level of the concha, and you remove the conchal cartilage and you make a big opening over here. So that is known as meatoplasty. Right? Okay. Next, we come to the modified radical mastectomy. So now, what is done in modified radical mastectomy? Modified radical mastectomy, you do the same like radical. Okay, so you do same like radical, you do, but over here, you see, once again, you have removed the posterior wall, preserving the facial nerve, but you try to preserve the conductive apparatus of sound. So the difference over here is you try to preserve the conductive hearing. Okay, you try to preserve the conductive hearing. How can you preserve the conductive hearing? You preserve the conductive hearing by preserving the same conductive apparatus. That means the tympanic membrane, the malleus incus stapes. Suppose that is involved in the cholestoma. This surgery we do for cholestoma, and this disease cholestoma is involving these ossicles. So now what will you do? Then you have to remove them and you reconstruct them. How do we reconstruct them? We reconstruct them by different types of tympanoplasty. Type 2, 3, 4, 6 that I have already taught you. Okay, right? So that is your modified radical mastectomy. Now the modified radical mastectomy has two aims. What are the two aims? Now the primary aim for modified radical mastectomy is same. What is that? Complete eradication of disease. Okay, so that will always remain the primary aim. Okay, but now we have a secondary aim, and secondary aim is preservation of conductive hearing, not the apparatus, preservation of conductive hearing. Now conductive hearing you can preserve by preserving the same apparatus or by making the new apparatus. Okay, right? Now let's look over here. So now steps of mastectomy. Okay, so steps of mastectomy, this is the surgery one pick. Now you see over here we have planned to do a modified radical mastectomy. Okay, so what we do is we give an incision. You see this is the EAC. You can identify the EAC over here. Now you can see that I have given some drill marks over here. So I am going to drill in this. This is your McEwen's triangle. So I'm going to start my drill over here. Okay, and then I'll proceed further. Right. So this is the place where you drill, and once you drill, you can start opening the cells and you will reach the place where you can identify the lateral semicircular canal. Okay, so that means I have opened the antrum and I will, open all the cells. Now in this, I have already planned a modified radical mastectomy. So you see the posterior canal wall, the posterior wall of the EAC and the posterior wall of the middle ear, I start drilling in from the very beginning. Okay, so trying to preserve the facial nerve, I keep on drilling all these structures. This over here is the tegmen, this over here is the sinus plate, this here is the posterior canal wall. Okay, so this here is the posterior canal wall which I have marked, which has the facial nerve. Right, now what do I do? In the next step, you see over here, I have removed all the cells. You can see the lateral semicircular canal. Okay, so you can see there is a good bulge of the lateral semicircular canal over here. Okay, so this canal is coming like this. This is the facial nerve. You can see the facial nerve in the posterior canal wall. It is going from here to here. Okay, now what else is visible? You can see the tympanic membrane which I have preserved. All right, you can see the incus. This is the incus marked with I, which I have preserved. You can see anterior to that is the malleus. So that also has been preserved. So this is a modified radical mastectomy where we try to preserve all these structures. Okay, right? Now let's look at another photograph. This is a second type of surgery where we have done a cortical mastectomy. So we were earlier not sure that we have to do a modified radical. So we have done a cortical mastectomy. So this is a very, very high posterior wall of the EAC. You can see the lateral semicircular canal. Now you can convert this into the modified radical or the radical. What you can do is you remove this wall of the EAC. Okay, so you can see this wall of the EAC has been removed, and once again you can see over here the lateral semicircular canal. The facial nerve is very nicely visible. You see this facial nerve has been preserved when the canal wall was removed. This is the tympanic membrane which has been preserved. This is the incus over here that you can notice. Okay, and then finally you can see the facial nerve, the incus over here, and the malleus anterior to it. Okay, this is the bulge of the lateral semicircular canal. Right? Okay, so now why I have shown you these photographs? Because this question has been asked in the exam. What is the question? Identify the structure marked as A. So this photograph was given in the exam. It was asked in the AIMS May 2018 exam. So now what do you see over here? So this is the middle ear photograph. You can see over here, this is the facial nerve. Okay, this bulge over here, this bulge is the bulge of lateral semicircular canal. Okay, this is surgical position, so you have to orient yourself surgically. And this over here is the incus. You can see the incus, the long, and then the lenticular process of incus, and below that this is the stapes. And anterior to the incus, we can also see over here that this over here is the malleus. Okay, so you can see the malleus, you can see this incus. So this is the incus over here. You can see the stapes. All right, you can see the lateral semicircular canal. All right, all these structures are visible. Now I have marked them for you. You may be asked a different structure in the next exam. All right, so you should be able to identify that. Suppose I ask you what is B, the B over here is malleus. Suppose I ask you what is C, the C over here is lateral semicircular canal. Suppose I ask you what is D over here, so the D over here is the facial nerve. Okay, and suppose I ask you what is E over here, so you see E, I have marked this structure as E, so E is the stapes. Right? Okay, so that was the question. In this question, the structure A was the incus. All right. So before we finish this topic, let us discuss canal wall down or canal wall up mastectomy. So this question is also asked nowadays. What is canal wall down and what is canal wall up mastectomy? Okay, canal wall down mastectomy is the other name for modified radical mastectomy. So what we do in modified radical mastectomy, you remove the wall. Which wall? You remove the posterior wall of the middle ear. But to remove the posterior wall of the middle ear, you have to also remove the posterior wall of the EAC. Okay, so that you can make it as one cavity. So that is known as canal wall. Okay, external auditory canal. So canal wall down, the canal wall has been removed. That is modified radical mastectomy. Okay, now what will happen because of that? We'll have a large cavity, right? A common cavity. Now we can also do canal wall up mastectomy. Now this is the latest concept for the etiquantral disease surgery, canal wall up mastectomy. Now what you do in canal wall up mastectomy, you open the mastoid, you open the middle ear, you drill and remove the disease from both the places, but you maintain a wall, a thin bony wall between the mastoid and the middle ear. So as you can see over here, this wall has been maintained. This is the middle ear, this is the mastoid. Okay, and this wall has been maintained. So this is known as canal wall up mastectomy. This canal wall up mastectomy is different from cortical mastectomy. Why? Cortical mastectomy, you drill only in the mastoid, you don't do anything in the middle ear. Here you are drilling and opening both the things, but you maintain this wall. Now what is the advantage of this canal wall up mastectomy? You see, the advantage of this canal wall up mastectomy, number one advantage is that there is no cavity problems. What do we mean by cavity problems? Cavity problems means like collection of debris. Okay, the debris gets collected, that may get infected. So if it gets infected, patient can have discharge. Okay, despite surgery. So there is no cavity problems. This cavity, they may also need regular cleaning and regular visits to the doctor. Okay, so that is also not required. Number two, it has better hearing. Okay, this has better hearing. Number three, what is the advantage? Patient can go for swimming. You see, in a canal wall down surgery, patient cannot go for swimming. Why? Because when the patient jumps into the water, a lot of water will enter into the ear. It's a big cavity, and now this temperature of the water is different from the core body temperature, and that will stimulate the labyrinth. Patient will immediately have vertigo. Okay, so canal wall down patient cannot go for swimming, whereas the canal wall up patient can go for swimming also. Okay, so these are the benefits of canal wall up surgery. Is there any disadvantage? Yes, there is a disadvantage. The disadvantage is that sometimes the colostoma may remain. It may be hidden below that wall and you may not see it. So the recurrence chances are more. You see, the recurrence chances, the recurrence of colostoma, okay, the recurrence of colostoma, these are more, the chances are more in canal wall up surgery, okay, the recurrence chances are more. So now, therefore, the canal wall up surgery is done, usually it is done in developed countries or high socioeconomic status people. Okay, so it is done in higher socioeconomic status or in developed countries. So now why it is done there? It is not done in low socioeconomic status because these patients will not come for follow-up. Okay, so you cannot know where there is a recurrence, right? So it is done only in high socioeconomic status people who are ready to follow up. And in these people, after 6 months, after 6 months, we do a repeat surgery, okay, that you can call as a check surgery, where we reopen the middle ear and the mastoid. We check if there is any regrowth of colostoma. If there is any regrowth, it will be a small regrowth, we remove it. If there is no regrowth, we just close it back. Okay, so a revision surgery is advised 6 months after the canal wall up surgery, just to check and make sure that there is no growth of colostoma inside the middle ear cleft. Okay, so remember, the chances of recurrence are higher in canal wall up mastectomy, but it has a lot of advantages compared to the canal wall down surgery. Okay.